evening, delegates and participants. Thank you for joining Shil Kanai. So today, West UP chapter of ISOBAP cordially invites you for a webinar on obstetric emergencies updates. And let me introduce our coordinator for today. So please change the slide. I welcome Dr. Reenu Goyal. Ma'am is a private practitioner in gynecology and obstetrics from Ghaziabad, and ma'am is also associate of Royal College of Obstetrician and Gynecology. Ma'am worked in GSVM Medical College from Kanpur and Sutures Hospital. So ma'am, I hand over the session to you, and your platform is here, ma'am. Thank you, ma'am.
Okay, thank you, Nishant.
Yes.
जरूरी नहीं रोशनी चिरागों से ही हो, जरूरी नहीं रोशनी चिरागों से ही हो, शिक्षा से भी घर रोशन होते हैं. Education, even in webinar form, is important. Good evening to all. I welcome you all in today's webinar on very different and difficult topic: obstetrics, emergencies and update. जो चीज आपको चैलेंज करती है वही आपको चेंज करती है. सो क्रिटिकल केयर वेरी इंपॉर्टेंट टू नो. नाउ आई स्टार्ट our further proceeding. I invite our pleasing, charming West UP ISOPERF Secretary, Dr. Seema Varshney. Welcome, Dr. Seema.
Thank you.
Dr. Seema is a dynamic, multi-talented personality and received Wonder Woman Award, Foxy.
Okay. Thank you, Reenu, for your kind, appreciating words. Hello, everyone. Myself, Dr. Seema Varshney, Secretary West UP Chapter ISOPAR. Extend a very warm welcome to all of you, and my sincere gratitude to President ISOPAR, Dr. Usha Sharma ma'am, and Secretary General Dr. Meena Samant, and patrons Dr. Narendra Malhotra sir and Padam Shri Dr. Usha Sharma ma'am, and guiding force and pillar of the West UP ISOPAR, President West UP Dr. Archana Verma ma'am, for continuous motivation, inspiration and guidance for this platform to gain lots of knowledge. I extend a very warm welcome to our chief guest, Dr. Alka Keplani ma'am, and Dr. Usha Sharma and Dr. Krishna Kumari as a special guest. And all the eminent speakers, all the chairperson and all the delegates who have logged in. अब मैं कहना चाहती हूँ 2 लाइंस आप सबके वेलकम के लिए. खुशियां नगमे बिखेर रही है, दबे दबे पाँव में कुछ कह रही है. आज दिन है पीपीएच एंड ऑब्स्टेट्रिक शॉक पढ़ने का. पधारे आज खास मेहमान हैं, तालियों के साथ इनका स्वागत करें क्योंकि ये हमारे वेबिनार की शान है. तो थैंक यू आवर चीफ गेस्ट and all the delegates, and today we are going to discuss very important subject, PPH and obstetric shock. We know PPH remains a major cause of maternal mortality worldwide. For making zero PPH, we have to follow some guidelines and keep ourselves vigilant enough throughout the journey of childbirth. But as we know, before starting anything, we have to seek blessings of God Almighty by lighting this auspicious lamp. So may I request all the dignitaries to please join for the lamp lighting, and may I request Raj to please share lamp lighting video.
Ya kundendu tusharhar dhavana, ya shubhra vastravrita, ya veena varadanda vanditakara, या श्वेत पद्मासना, या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता, सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा. शुक्लां ब्रह्म विचारसार परमा, आद्यां जगत् वीणा पुस्तकधारिणीम् अभयदाम् जाड्यान्धकारापहाम् हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्।
Thank you, everyone. Now, may I request Dr. Reenu, please invite our guiding force, President West UP ISOPAR, for welcome and presidential address and program overview, Dr. Archana Verma ma'am.
जब हौसला बना लिया ऊंची उड़ान का, जब हौसला बना लिया ऊंची उड़ान का, फिर देखना फिजूल है कद आसमान का, फिर देखना फिजूल है कद आसमान का। एक के बाद एक वेबिनार मींस एजुकेशन कहना है हमारी डायनामिक मैजेस्टिक वेस्ट यूपी चैप्टर आइसोपर की प्रेसिडेंट, फॉक्सी वाइस प्रेसिडेंट डॉक्टर अर्चना वर्मा का। चलिए उनका दीदार करते हैं। वेलकम मोस्ट मल्टीटास्किंग पर्सनैलिटी डॉक्टर अर्चना वर्मा फॉर हर प्रेसिडेंशियल एड्रेस। वेलकम डॉक्टर अर्चना वर्मा।
I really welcome you all. I'm so proud of my team, and especially Dr. Reenu, Dr. Seema Washne, and whole West UP and our patrons who for guiding us, and all our main ISOPA president and Foxy Secretary General for giving us opportunities to carry on the work. And so we are really thankful, and thankful to all our special friends, Dr. Vidya Thobi, Dr. Poonam Kumar, and Dr. Poonam Kumar Verma, Shiv Kumar Verma ji, in saving the mothers and saving doctors also. And so because this nowadays trend is to take care of the woman health, and so all this is especially the obstetric emergency updates are especially to make the readiness and alertness and awareness for the postpartum hemorrhage deaths, which is now being tackled on by the government level also, and we are reaching the SDG goals, I think, for sure, with the great work with the I think Vidya Thobi ji and Dr. Poonam, they will throw a very good light. And now I hand over to the Kanchan Prasad to say a few words, and all my other two great speakers, Archana Sharma and Dr. Vinita Mittal. So proud of you that you people have made such a wonderful program, and my thankful thank to all.
Dr. Kanchan
is a very active member of ISOPAR. Reenu, kindly introduce her in 2 lines.
And in the meantime, Reenu, please see Dr. Alka Kriplani has joined. Otherwise, please start the inauguration timely.
Thank you so much, ma'am. Thank you so much, Archana Verma, ma'am, to give me the opportunity to give the program overview. Myself, Dr. Kanchan Prasad. My heartfelt gratitude to ma'am. And West UP ISOPAB, under the leadership and guidance of patrons Padam Shri Dr. Usha Sharma ma'am and respected Dr. Naren Malhotra sir, President Archana Verma ma'am, and Secretary Dr. Seema Washne ma'am, Treasurer Dr. Archana Sharma, and Dr. Renu Goyal ma'am, we are committed to improve maternal and neonatal health and always come up with such academic events on regular interval with updates, evidences, and clinical expertise. Today, we will be having discussion on 5 important aspects of PPH with stalwart speaker, Dr. Vidya Thobi ma'am, a great mentor, Dr. Poonam Shiv Kumar ma'am, whose mission itself is moving towards zero PPH, Dr. Ajay Mane sir, providing medical legal services for last 18 years free of cost, Dr. Archana Sharma ma'am, a renowned gynecologist, and Dr. Vinita Mittal ma'am, having vast experience and knowledge. The maternal mortality reduction remains a priority under Sustainable Development Goal 3 by United Nations, and India looks to achieve the SDG target of MMR less than 70 per 1 lakh live birth by 2030. And as we all know, PPH is one of the major cause of maternal mortality. So we need to re-emphasize this topic and update ourselves again and again to achieve the target. There will be pearl of wisdom from eminent chairpersons, Dr. Pratik Tambesar, one of the most dedicated and committed figure in FOXI and ISAR and other organizations, a teacher par excellence. Dr. Nisa Singh ma'am, a hardcore academician, Dr. Neha Gupta, Dr. Preeti Vaishya, Dr. Rasmi Sharma, Dr. Ruchika Garg, Dr. Manisha Agarwal ma'am, Dr. Sasmita Swain ma'am, Dr. Samta Gupta ma'am, who will be giving their valuable inputs. And there will be felicitation of Dr. Niharika Malhotra and Dr. Neha Gupta for brilliant newsletter. So without wasting much time and with the blessing of our chief guest, Dr. Alka Kriplani ma'am, Dr. Usha Sharma ma'am, and and special guest, Dr. Krishna Kumari ma'am, I request Seema Vasne ma'am to proceed further. Thank you so much, ma'am.
Thank you, Dr. Kanchan, for your very crisp program overview. And now have Dr. Alka Kriplani ma'am joined?
नमस्कार मैम, आपका इंतजार कर रहे हैं आइसोपर्व में. बिल्कुल आइए मैम, आपका इंतजार कर आइए मैम.
Is she coming? Reenu? Dr. Reenu?
Seema, you introduce Dr. Usha madam first, then you.
Okay. Now I invite Dr. Archana Sharma ma'am for invite and welcome Dr. Usha Sharma ma'am. She is our chief guest and very humble, very soft spoken and ever smiling. Dr. Usha Sharma ma'am. Dr. Archana Sharma is a director of Ganesh IVF Center, Ghaziabad, and treasurer of West UP ISOPAR. Dr. Archana Sharma, kindly come and introduce Dr. Usha Sharma ma'am.
Thank you, Dr. Seema, for giving me this opportunity. A very good evening to one and all. I really very humbly welcome all you all and express my gratitude to our gorgeous president and a distinguished academician, Dr. Usha Sharma ma'am. President ISOPAR.
कुछ दबा गया है.
Dr. Archana Sharma ma'am, you are not audible. Are you there?
I think she has already introduced me and I should not waste any time and say a few words, and then we are all eager to hear the scientific program.
Yes, ma'am. Please say a few words of pearls of wisdom.
Can you all hear me? First,
Yes.
tell me that.
Yes ma'am.
Yes, ma'am.
You
Madam,
can hear.
we are very happy to have you, and because you are the really I must say that caretaker for this West UP ISOPA. We have
Not only
grown
West
under
UP,
your-
वो तो आप हैं अर्चना जी. I have no delusions about myself. अब मुझे दो एक शब्द आपके तारीफ में बोलने दीजिए. It is indeed my proud privilege to attend today's webinar organized by West UP chapter of ISOPAB on obstetric emergencies. And the best part is updates today is on one topic targeted PPH, which we all know is a condition when any obstetrician, a junior, senior, or a very senior consultant, it's really a nightmare for everyone. I am happy to share the dais with a very eminent gynecologist of India, Dr. Alka Kriplani, past president FOXI. Now coming to Dr. Archana Verma, whatever I will say in her praise is less. She is a gem. She is very active. She is academic. And best part is she is a superb human being. Always finds good points in others. I have never heard her talking anything evil about anyone. That makes her a superb person. Congratulations. Now, I'm very eager to hear from all the learned speakers who have really taken care in detail. PPH is a nightmare, we all know. Moving towards zero PPH would be a dream come true. Medical legal aspects of PPH, in which documentation is very, very important. We all probably do not realize the value. You don't have to document when PPH is occurring. Do manage the PPH, but after that, be very careful in documentation. Then next we come that we have managed PPH and we end up in obstetric shock. So what do? Next is, depending on the level of the shock, you have options, but blood transfusion is one of them. And we all need to know when we should be transfusing and how much. Which component of blood is important? Now, as I will say that Dr. Kanchan Prasad has already detailed the scientific program, but today I am eager to hear Dr. Vidya Thobi, Dr. Poonam, Dr. Ajay Mane, Dr. Archana, and Dr. Vinita Mittal. And the best way to prevent PPH is active management of third stage, which is recognized worldwide. I really congratulate West UP chapter for its active work in ISOPAR, and Archana ji, wherever she goes, be it Foxy, be it ISOPAR, she is there to create dynamism. The speakers will update us today, and the chairpersons are going to add their pearls of wisdom to it. Happy learning and long live ISOPAR.
मैम आ रही है डॉक्टर अलका.
Thank you, madam. Thank you, Usha, madam, for such a kind words. And I must
You
say,
are worth it. You are worth it, Archana ji.
If someone thinks so good about that person, has to be very, very good. Thank you.
Now clean bold.
Welcome, Dr. Alka.
Thank you for your kind words. Actually, I am in awe. I think I haven't heard Dr. Usha Sharma many times, but listening to her is an absolute pleasure.
Ma'am, I have to introduce and welcome you, ma'am, first.
Okay.
I am very delighted to invite our chief guest, very charming, versatile, and very distinguished person, Dr. Alka Kriplani, ma'am. And दो लाइन आपके लिए कहना चाहूंगी. आप आए तो बहारों ने लुटाई खुशबू. आप आए तो बहारों ने लुटाई खुशबू. फूल तो फूल थे, कांटों से भी आई खुशबू.
अरे वाह.
Here it comes, ma'am, and you need no introduction, but to do official, I want to say something for you. You are director and head of the Department of Gynae Ops and ART in Paras Hospital, Gurgaon, ex-professor and head of the Department Ops Gynae, AIMS, Delhi, and past President Foxy, GESI, DGES, and AOGD, and editor of Asian Journal of Ops and Gynae Practice, and co-chairperson FIGO Menstrual Disorder Committee 1618, and received so many awards. She has received Padam Shri for distinguished services in medicine, and by President of India 2015, and Dr. B.C. Roy National Award for Eminent Medical Teacher 2007, and published so many papers and delivered so many talks. So here you are, and we want to hear your pulse of wisdom, ma'am.
Thank you so much for your such sweet and kind words. So as I started, Dr. Usha Sharma, it was wonderful listening to you. And I'm sorry I may not take everybody's name, but thank you so much for the sweet introduction. And what to say of Archana? अभी आधे घंटे पहले भी मैं उसके साथ थी, अभी भी हूँ. Archana is flying very high and taking all of us along. Her energy is really to be appreciated, and I can see the metamorphosis. She is so focused, so involved, And I will be failing in my duty if I don't acknowledge ISOPAR. This organization for 2-3 decades I'm watching. It was basically Patna gynecs who were really doing a great work, and now that it is like infectious, it is spreading, and you people are doing such good work. Today's webinar, I would say, when people ask me, give us talk on something endoscopy or IVF, I feel more important. This PPH is a very, very relevant subject because it concerns masses. And still there is so much of morbidity, near miss mortality and mortality because of PPH. And when I was president, I did these workshops on PPH, and I tell you, they used to be, people used to flock around. If you give correct knowledge and the teaching to colleagues, बिना बुलाए भी सब लोग इतनी भीड़ होती थी. So I must congratulate you people for picking up this topic, and 1,000 times it should be reiterated how to prevent and how to manage PPH, because all of us face it. And believe me, I never fear anything in endoscopic surgery or anything in cancer surgery. But when a delivery happens, everybody expects that nothing wrong should go. And PPH is such a serious issue, and you don't know who will end up in PPH and how severe it will become. So it's a very, very important topic. I congratulate ISOPAR. I congratulate West UP ISOPAR. I congratulate all the speakers. And I congratulate my dear, dear friend Archana and Usha Rani, who really impressed me today. And I wish you a great evening and happy learning. Thank you.
Thank you so much, Dr. Alka, madam. I think I would just want to make it official also that one day I was almost dancing in a conference evening, and then Dr. Alka, madam, was also there, and we were going all around her like a moon moves around, and the earth moves around sun, and we were almost crazy to say hello to madam. And then after some time, madam said, Archana, you dance so well. After some time, Archana, why don't you come and meet me? Why don't you come to the Foxy? I said, madam, we are very, very small people. How can we join Foxy? Then she said, okay, just don't worry. We will help you. And then was the day I am totally my pure, actual, real mentor is Professor Alka Kriplani, madam. Thank you, madam.
Love you.
And
it's
another
your
great
own
person
hard
is
work.
Dr.
It's your own hidden talent. It's your hard work, and such a good person you are. Such an honest person you are. Such a hardworking person you are. So you are going to places what you deserve.
Thank you, madam. Thank you.
I second whatever you have said. I could add few more adjectives to it.
Usha ji, I'm highly impressed with your talk. Very, very to the point. Love you.
Thank you, ma'am.
So do I, and I praise you as well, Alka ji, for all your achievements.
Yeah, Dr. Alka Kriplani से ना direct मिलने से एक और ही अलग है. And another
मैं
my
मिली
great.
हुई हूँ. बहुत बार एम्स में उनसे मैं मिली हुई हूँ. That's why I'm saying that she is such a nice person.
Yes, एक बार मैडम मीटिंग रखते हैं कोई अच्छी सी बढ़िया सी. अभी हमारा प्लान था ना एनुअल CME करने का, तो अभी just because of the corona, within I think 1 month again I'll be back.
Good.
And all the chief guest and guest of honors will be the same, irrespective any change anywhere. And another great friend I met some like this only in one of the CME, Dr. Poonam. I just went to her. I said, I really like, I think, I don't know what spiritual, something miracle happened and how I met her and how I was really interested to join. When I just listened to her talk, she was talking on PPH. Manika, oh my God, madam, I just want to be with you. And you are looking so perfect. From where are you? She said, I'm from Sevagram. Oh my God, I have heard a lot about the Sevagram. I have never been there. So please be with me. And that was the day she really transformed me. And we made whole year we were doing 0 Pph programs, and she is a best person for Madam Pph awareness. And as you said, workshop, we were waiting to make few workshop also, and I think I will talk to you.
No,
Madam.
no, Poonam is very good for many things. She is doing so much in WHO and other government. Poonam is again a very, very blessed person.
Thank you so much for your blessing.
Thank you. Thank you, ma'am. Thank you.
Thank you. Thank you all for your very appreciating words. Now I invite Dr. Renu I request Dr. Renu to please invite a special guest. Dr. Renu.
Yeah, hello. Now I am inviting our today's special guest, well-known personality, Dr. Krishna Kumari. Dr. Krishna Kumari, she is gold medalist in MD, senior consultant, Medicover, Women and Child Hospital, Hyderabad, national coordinator, FOXY, 2021-22, national editor, Jogi, member of SAFOG. Ma'am, you are welcome in our webinar and deliver your pearls of wisdom and best wishes for us.
Thank you. Thank you so much, Dr. Renu, for your kind introduction. At the outset, I would like to convey my greetings to Dr. Usha Sharma and Dr. Alka Kriplani. It's a pleasure meeting you all, even though it's virtual, and listening to both of you be a part of this lovely inauguration. And I would like to thank the ISOPAP West UP chapter for inviting me today for this wonderful program on postpartum hemorrhage. We all have heard the program from Madam Dr. Alka Kriplani and Dr. Usha Sharma, and also the program has already been introduced. And I would like to most importantly thank Dr. Archana Verma. As you have all said, yes, she's such a lovely person, golden-hearted, and of course, a very vibrant person. And in the last year, when I came to know her more closely and dearly, really, she's such a lovable person. I think all of you, when you say that you love her, I again reiterate the same things which my previous speakers have said about you, Dr. Archana. You're such a really lovely person and a hardworking person. And definitely we wish you to go to very much higher and higher places. And the other members, Dr. Archana, Dr. Archana Sharma, Dr. Seema Varshne, and Dr. Renu Goyal. I think I know very little about them, and my association with them is very minimal, but they come out as beautiful persons and very lively. And a few minutes also they have conveyed so much of, they welcomed me with such a wholehearted way. I think really it's a wonderful experience being with you all today. So as far as the program is concerned, I know PPH is a very tough thing to tackle. How much ever we talk about it, how much ever we try to prevent it, still it's going on. And even though fortunately our country has seen a big drop in the maternal mortality, and also PPH management has improved a lot, we still have to go to have to reach much deeper, smaller crevices, because the problem now is not only bringing down the mortality, but being able to talk about the maternal near miss, the morbidities. These are all what mortality is just a tip of the iceberg. Much below that is so much of unknown territory where we do not know what is happening to our women who have almost gone there and come back, the so-called maternal near miss. So I think it's very important that prevention is primary aspect, and going into the knowledge more deeper and deeper and finding the best methods would be a wonderful way, a good learning experience. And I'm looking forward to listening to all the stalwarts today in the program. Thank you all so much for inviting me. And thank you, Dr. Archana, Dr. Seema, and Dr. Renu. Thank you so much. Thank you,
Thank you,
Dr.
madam.
Sharma, madam, and thank you, Dr. Alka Kriplani.
Thank you, madam, for your kind appreciating words and with a great smile. Your smile is very
Thank you so much.
मैं बहुत अच्छी स्माइल है आपकी और आपने जब बोला तो ऐसा लगा कि फूल झड़ रहे हो.
Thank you.
Okay, thank you all the dignitaries. And now we start our academic session. The topic is postpartum hemorrhage is still a nightmare in our country, and etiology of PPH is diverse and management depends on identifying the risk factor and causes and treatment in time accordingly. To throw light on this topic, very important and very difficult topic, we are having a very eminent speaker, Dr. Vidya Thobi, and to chair her session, we are having very eminent chairpersons, Dr. Pratik Tambe. Can we have the CV, please? Very humble, very soft spoken, dynamic, Dr. Pratik Tambe. He is ART consultant and gynae endoscopic surgeon, and he has done international diploma in advanced laparoscopic surgery, France. He has been trained in ART in Belgium and clinical embryology and ICSI at London and Singapore. He is chairperson AMOX endocrinology committee and governing council member of ICOG, recipient of many awards and editor of many books. So over to you, Dr. Pratik Tambe, for chairing this session. And next chairperson, very sweet, Dr. Nisha Singh. Can we have the CV, please? Dr. Nisha Singh is unit head and in charge of Genital Cancer Control Unit KGMC Lucknow. She is fellow of ICOG, secretary UP State AGOI and Lucknow Obs Gynae Society. So may I request Dr. Nisha Singh chairing the session, kindly introduce our speaker, Dr. Vidya Thobi. Over to you, Dr. Nisha Singh.
Yeah, thank you so much, Dr. Vaishni, and it's a pleasure being here. And I thank Dr. Archana Verma in particular for making me part of this program. And because I'm delighted to have Dr. Alka Kriplani, who's been my teacher. So it's really a pleasure being here with all of you here. So may I have the CV slide of Dr. Vidya Thobi, who is our first speaker. Can we have a slide?
Change the slide. Please change the slide.
Yeah. So as we all know that this CME, the webinar is about emergencies, the obstetric emergencies, and PPH is the first topic that we are going to deal with. And so the topic that has been allotted to Dr. Vidya Thobi is PPH, a nightmare. May I have her slide, please? Though I know her personally and I would like to speak a lot about her. So we are delighted to have Dr. Vidya Thobi, who is the professor and unit head, Department of Obstetrics and Gynecology at Al-Amin Medical College, Vijaypur, Karnataka. Madam, as you all know, is the chairperson of the Food and Drug Medical Legal Surgical Equipment Committee, FOXI 2018 to 20, and she received the Best Committee FOXI Award, the Dr. Mehrudara Ansotia Award in 2020. She is ICOG Governing Council member. She has got the FOXI Champion Award in 2019. National Corresponding Editor of Jogi, organizing chairperson of many conferences. She has been the president of the Bijapur OBG Society and secretary also of the Bijapur OBG Society. Lots of publications in various books and contributions to FOXI Focus. She has been a speaker at national and international conferences, and she has organized various CMEs, workshop and awareness programs. She is advisory faculty of boards, Rajiv Gandhi University of Heart Sciences, and postgraduate and undergraduate teacher for 30 years. Of course, she's in one of the medical colleges. So we welcome you, ma'am, and we are waiting to hear from you about PPH as a nightmare. Thank you.
Professor Nisha, and everyone here, especially West ISOPO. Can I share my screen now? Hope you are able to see my screen in the slideshow.
Ma'am, it's not it in the slideshow mode, ma'am. Can you please stop share and share again?
Yes, can you see my?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
So at the outset, I thank West UP chapter of ISOPA and the secretary Seema Varshine and Reenu Goel. And my thanks to Dr. Archana Verma, who is my dear friend and very great organizers. My regards to Dr. Usha Sharma ji and Professor Alka Kriplani. And thank you very much, my chairpersons, Dr. Pratik Tambe and Dr. Professor Nisha. So, n number of times we talk of PPH. PPH is really a nightmare. We know that once we get the call that there is a PPH, we get alert, and many times we perspire also. So women are not dying because of the disease we cannot treat. They are dying because of societies have yet to make the decision that their lives are worth saving. So as Mohammed Fatala says, the PPH, we know that more than 529 lakhs maternal deaths occur from the complications of pregnancy and childbirth every year. And most of these maternal deaths, they occur in third world countries. 60% of the maternal deaths occur in the postpartum period when the prevention strategies are often lacking. PPH is 50 times commoner in these countries. So low middle income countries, the PPH is more common. As Professor Krishna Kumari was talking about, the maternal mortality has come down, but even then there are so many n number of cases of PPH per year. The 5 most common cases we always discuss about the pregnancy-related mortality are hemorrhage, sepsis, unsafe abortions, hypertensive disorders, and obstructed labor. Of course, many of them, these causes, they cause hemorrhage. Now, about the definition, we all know about the definition: any blood loss from the genital tract during delivery more than 500 ml. ACOG defines decline in the hematocrit, but we always think of hemodynamic instability, whatever the blood loss is there. So primary PPH occurs within 24 hours and secondary PPH occurs up to 12 weeks post-delivery. And mostly the common cause is infection or retained placental tissue. So remember this, that every woman in labor is at risk of PPH. 2/3 of those with PPH, they don't have any identifiable risk factors. So we have to be prepared in all labors. And as we were talking about the decline in the maternal mortality due to PPH, mainly the 60%, these are managed because of active management of third stage of labor, which we practice in all women in labor. All postpartum women must be closely monitored for PPH. We talk of 4th stage of labor, and these all strategies prevents 60% of the tonic PPH. Now, whenever we talk of emergency obstetric care, the interval between the onset of complications and death, if you see, the PPH tops the list. That is, within 2 hours, the patient can die. Just a simple case I have just taken. A 26 years old G3P2 live birth 2 and previous just normal delivery. She does not have any risk factor, who was admitted in active labor at term. She delivers a healthy baby boy weighing 3.2 kg. Amstel was done, placenta expelled after 10 minutes. And again, the nurse notices sudden gush of bleeding per vagina. So uterotonics were given, uterine massage was started. After the massage and bimanual compression, the uterus was still remained flabby. There was no IV line because just patient came and delivered. So she came in active labor. IV line was started, 20 units of Talks, uterotonics was given. Again, there was a large clot which expelled and patient collapsed. The pulse was 120 per minute. Systolic BP was 80 and shock index was 1.3. So again, methergine was repeated. Hemoglobin had dropped to 6 and blood and blood products were arranged. Condom catheter was inserted, tamponade, anti-shock garment was applied. Patient was monitored and next 24 hours and general conditions stabilized. So why I say about the 4 stages, in some of the patient, this patient was comfortable, but there was another patient who complained of a perineal and rectal pain. She delivered normally and then suddenly she collapsed. The cause was the uterus was displaced and there was a broad ligament hematoma. So sometimes there is a atonic Pph and traumatic Pph together. So for the other patient, the laparotomy was done under general anesthesia. Now, why I want to insist is there is a golden hour. As the more time elapses between the point of severe shock and the start of resuscitation, the percentage of surviving patient decreases. So there, once the metabolic acidosis sets in, then the chances of revival becomes less and less. The golden hour is the time in which resuscitation must begin to achieve the maximum survival. Now, what are the key points in the golden hour management of Pph or 0 hour management of Pph? One is almost most important is call for help, ABC assessment, that is airway, circulation and breathing. 2 wide bore cannulas should be inserted, collection of blood for investigation, catheterization, palpate the uterus, massage, find out any cervicovaginal exploration. You have to do uterotonics, mechanical methods, and there should be a color coding and shifting to ICU and HDU. And most important is counseling and consent. The medical legal aspect definitely we are covering today by Dr. Ajay Mane. The steps to Pph is, remember, predict, prepare and handle, and always assess the risk factors. So we know the antepartum risk factors like antepartum hemorrhage. Previous Pph is another important factor. Any previous manual removal of placenta over distended uterus, adherent placenta, intrapartum operative deliveries, any manipulation, prolonged labor, or any infections in cases of premature rupture of membranes or any other cause. And postpartum, most important is genital tract injury, retained placenta, and always suspect uterine inversion if the shock is disproportionate to the bleeding. Then there can be a congenital or acquired coagulopathy. So remember rule of 30 and shock index, 30% of the blood loss, more than moderate shock. Pulse rate if there is increase in more than 30, respiratory rate more than 30, systolic blood pressure drop by 30, urinary output less than 30 ml per hour, and hematocrit drop more than 30%, and to be kept at the absolute value of more than 30. So remember the shock index, which predicts that pulse rate divided by systolic BP normal is 0.5 to 0.7, and more than 0.9 indicates the state of shock that needs urgent resuscitation. So whenever we talk of etiology, the 4 T's always we remember. One is tone, tissue, trauma, and thrombosis. And always in 80% of the cases, we know that it is atonic uterus. It is whenever we talk of blood loss, it is very, very easy to miss. The physicians, they underestimate blood loss by 50%. And the most important is a slow, steady bleeding can be very, very fatal. Most of the deaths from hemorrhage are seen after 5 years because sometimes the abdominal or pelvic bleeding can be hidden. So this is a simple blood assessment chart. Always we keep it in the labor room, and accordingly we can just judge how much the blood loss can be. So this is just a visual view chart, and all of us should know that how much is the blood loss. This is around 30 ml. If the bleeding is over your table, it is more than 1,500 ml. Of course, you have to judge according to the hemodynamics as well. So this is a simple brass drape we know, which is a calibrated one, where we can judge how much can be a blood loss. Now, what are the challenges in the diagnosis? Why we talk of this nightmare? Because sometimes there is a delay in diagnosis because of concealed hemorrhages, and sometimes there is alteration in pulse and BP. The flabby uterus we just miss in atonic Pph, and so on. So many comorbidities will be there with the patient. Patient is anemic, or if the patient is having preeclampsia or hypertensive disorders of pregnancy, the only 300 ml blood loss can be also be fatal. So we have to identify the risk factor, and visual estimation of blood volume should be done. correctly, because sometimes it is under and overestimation of blood volume can also occur if it is mixed with amniotic fluid and all. So you have to do correct judgment. You should have a correct judgment of blood loss. Now we're talking about prevention, the active management of third stage of labor. Always remember to give uterotonic drugs within 1 minute of delivery of the baby. The oxytocin should be given 10 units intramuscularly. Controlled contraction and uterine massage after the delivery of the placenta. There is one more talk on obstetric shock, so I will not go into the detail, but on the symptoms and signs, whatever the compensatory mechanisms occur in the body, we have to judge how much can be the blood loss. So if the patient collapses, definitely the blood loss is profound, and the blood loss can be up to 2,000 to 3,000 ml, or she has lost 35 to 45% of the blood loss will be there whenever the patient collapses or patient has air hunger or anuria. So you should always watch these symptoms whenever the patient has PPH. And this is a proposed classification by Benedict. Here also you can see there is an alert line. When the patient loses around 500 to 1000 ml, you should be having the alertness. You have to observe, you think of replacement therapy. So as the blood loss increases like 1200 to 1500 or more than that, you have to do active management. You have to call for help. You have to replace whatever the volume. And then if the patient goes into the profound shock, you have to do critical active management. So this is a simple alert and action line one should remember. Now, whenever we are talking of PPH, remember simple hemostasis. So what is one thing is you have to evaluate the vital parameters of the patient and the amount of blood loss. Start the resuscitating A, B, C, that is airway, breathing, and circulation. So assess the shock, assess the cause, arrange for blood, that is all A. B is a big bore cannula. Remember 16 gauge gray color cannulas you should keep ready in your labor room. And C, you have to do CBC cross match and do the coagulation screen. The second one is you have to find the cause, that is a tone, tissue, trauma, and thrombing. Check for the uterine tone, whether there is any trauma. Look for the placenta if it is complete or incomplete, or any lobes missing in the placenta. Remove all the membranes and start bimanual compression. Now this is about the fluid resuscitation, multiple large bore IV axis. I told about the gray color cannula which can infuse the fluids faster. For 1 ml blood loss, you have to infuse 1:3 ratio crystalloid, colloids and blood products to maintain hemoglobin near 10 gram% during active bleeding. 80% if you do more than 80% volume replacement, remember it causes dilutional coagulopathy. You have to maintain the tissue perfusion, and you have to send for FFPs, platelets, cryoprecipitates, all the replacement therapies. Now, this is how the bimanual uterine massage is done. The bladder should be empty, your fist should go inside, the other hand over the abdomen, and you have to compress. Now, third one is a drug therapy. It is a very vast topic. I'll not talk much about it because everybody knows about the drugs, and these uterotonic drugs we know all: oxytocin, ergometrin, prostaglandin, misoprostol, and prostaglandin F2 alpha. These are the drugs, and how they act. The most important about the oxytocin is inexpensive. It has got a minimal side effects, but it requires also cold storage, and it acts within 2 to 3 minutes. That is an advantage. And the ergometrin, though it is a long acting, it is contraindicated in hypertension, more expensive, and it demands cold storage, as is the carboprost. Misoprostol is again another drug which is commonly used. It is also long acting, it is inexpensive, and it does not require cold storage. So in combination, many of the peripheral hospitals, they do use misoprostol, and now we know about the action and this one. And one thing I want to stress here is never ever give prostaglandin intravenously. You have to give intramuscularly only. And the precaution for this prostaglandin is you should not give in during patients of asthma and heart disease. So these are not given. Whatever the recommendation till now, they say that oxytocin is the drug of choice. There are many trials now. The recent one, these are the trials, and recently the carbetocin has come. Now the carbetocin is again a synthetic long-acting analog of oxytocin, which is created by making several modifications to the oxytocin molecule. It is available now, and it is most important is it is stable at the room temperature, convenient while presentation, and it has got a similar efficacy and safety profile as oxytocin. Earlier it was very expensive, but it is now available at lesser price. Many companies have come up. So carbetocin significantly reduces the need for additional interventions and uterine massage, or need of additional uterotonics, reduce the blood loss less than 500 ml in most of the women. So we know about the Champion trial, and we know about the outcome also. So carbetocin is now recommended by WHO also. Now another thing is what they were talking about the injectable oxytocin, that they have to have a syringe, and the peripheral healthcare workers, they have to be trained to give injection. But this is another Uniject device which has come, which is a pre-filled syringe. The fourth thing I just wanted to talk about is a balloon tamponade. If the bleeding continues, you have to talk of non-surgical uterine compression. We have done bimanual compression. Then you can talk of give this balloon and condom tamponade. You can get it prepared immediately. Now UPT and other things are ready-made. Tamponades are also available. We know our own Chhattisgarh, Dr. Nalini's balloon tamponade as well. And additionally, in traumatic PPH, the injection tranexamic acid is also useful. These are the few pictures of commercially available balloon tamponade in use. Okay. And then comes about the sutures. If bleeding still continues, then you have to go for the various compression sutures, artery ligations like uterine and hypogastric, or you can go for uterine artery embolization. So these are the various compression sutures we know of, like B. Lynch. Then we know of Heyman sutures. We have our Gunashila stitch, global stitch, which Dr. Gunashila was there, which was popular, and then chose multiple square sutures. These are the compression sutures. And if you have got the competent radiologist, then you can go for systematic pelvic devascularization. So this can be another option. So there are other procedures like uterine, as I have described already, uterine embolization, stepwise devascularization, internal iliac ligation, and the last resort is a hysterectomy. So for the interventional radiologist, if you have a uterine artery embolization in your institute, definitely sometimes it is very useful. The tissue, the retained placenta, inspect the placenta, as I told me, for the missing cotyledons, explore the uterus, and see something about the important thing is abnormal implantation. So delay of the placental delivery more than 30 minutes seen in 6% of the deliveries. Prior retained placenta increases the risk, and the risk we know that it increases with the prior cesarean section, curettage, or any uterine infections, increased parity, and previous cesarean scar and previa increases risk up to 25%. And most patients, they don't have any risk factors as well. And occasionally we get this accentuate lobe left behind. So this is very important, again, a cause of postpartum hemorrhage. So you can see here placenta, increta, percreta, accreta, these are the other causes. So manual removal of placenta under anesthesia is a treatment. And the second most important cause of PPH is traumatic PPH. Trauma can be cervical, vaginal laceration. So whenever we want to treat this traumatic PPH, you have to obtain good exposure, inspect cervix and vagina, and worry about slow bleeders, and treat hematomas. This is the take-home message, that the slow bleeders are very dangerous. So repair the laceration, ligate the vessel stepwise, and the hysterectomy, if required, is the life-saving. So repair of the cervical, cervical laceration or cervical tears is done. You have to see the apex and frog lip. You have to go in and suture it. Scissoring hysterectomy is another option for PPH. You can see in the lower segment, there is a bulge. It is a case of placenta accreta. So really in such cases, it is a really nightmare when you open the lower for cesarean and you see such picture. So the such picture, if you see really it is nightmare, you have to call the team and multidisciplinary approach is required to treat this patient because it is definitely a life-threatening condition. So you can see the vessels and it is just threatening to us. Okay, and the most common complications is a rupture uterus when the obstructed labor cases come, and the realizing, diagnosing rupture and managing rupture is again a skill. So you must, every person should know internal iliac ligation and obstetric hysterectomy, both incompetence, and whenever incompetent obstetricians they open, then it is really very difficult to manage this case. The another traumatic PPH we get is a vulval hematoma. So vulval hematoma, you have to drain and you have to just see if there are hidden hematomas. We know the supralevator and infralevator. I will not go into the details because of the paucity of the time, because every cause of PPH is again half an hour discussion. So I just want to tell at the last that 3 Ds causing the 4th death. One is delay in the recognizing and seeking help. One should know how to diagnose. Many times it is a mixed picture, like it is a traumatic or atonic. Delay in transport and reaching the medical facilities, 2nd D. That is when to shift. That is also, we go on treating medical management, when to again jump into the surgical management and the facilities, the blood availability of the blood and blood products. These are the again factors which do matter. And 3rd is delay in the receiving an adequate treatment. So what and how to give an early and appropriate treatment is another D. So these are the important things one should know. So where to shift is also important. Delay in shifting an important cause of death. Think of shifting as early as possible, shift as quickly as possible, and you have to communicate to the patient, attendant, to the tertiary care personnel, and shift to the tertiary care center with OT, ICU, blood bank and personnel. These are very important. We are discussing medical legal aspects of PPH. So this documentation is very, very important. One is you have to shift preferably in ambulance with nasal oxygen on flow, with 2 IV lines with fluid on flow. It can be a lifeline for that patient. And documentation is very important. The event should be written in sequence. IV fluids, what are given, what has been, what was her output, how she has come, what was the diagnosis, what are the drugs administered. Communicate to personnel at a tertiary care center. So these we know the anti-shock garment, and it acts like it churns the blood from the capacitance vessel to the vital organs, and it is really a life-saving. And it is now when every hospital should have, whenever we shift the patient, we apply this anti-shock garment and shift. So this is lastly I want to say about this algorithm. You remember that is hemostasis. One is H is ask for health, assess vital parameters, blood loss and resuscitate, establish the etiology, ensure the availability of blood and blood products, massage, oxytocin infusion, all uterotonics, everything, think in line, and you have to know how they act and which way you should give, and how to give, what is the dosage. You have to know everything about this, which should not be given intravenously, in which drugs are contraindicated, in which conditions, that also should be known. You should have a anti-shock garment. Shifting to the your OT should be well equipped. You have to rule out all trauma. Start giving by manual compression. Tamponade, you can use balloon and uterine packing sometimes. Sandwich technique, apply compression sutures as well. Systematic pelvic devascularization, you can try uterine, ovarian and quadruple internal iliac. If you have interventional radiologists, try that if appropriate uterine artery embolization has been done, and if required, you can go for that. Or you should be trained for subtotal or total this obstetric hysterectomy. Everybody in your hospital should have, every hospital should have this crash kit. These are the things they should be available daily. One staff sister should check the expiry and the drug, whatever the available in this crash card. And we train this in our Manyata Laksha program. So every day the sister who enters the labor room should check the availability. So it should have all these things, Branula, right from the Branula to all the drugs, drip set, IV fluids, then even the intubation material, everything should be ready there. So all those things should be there for the crash cart and emergency tray. Now this is a simple Pph chart which has been designed by Dr. Sheila Mane. It is available on the Foxy website. This also can be stuck on your labor room and OT. Then you can follow all these things, because sometimes whenever there comes the Pph, our brain gets blocked, and then we don't know how to go about it. So we become panicky. So this chart is very helpful what to do in sequence. And you can also, by the side of your blood loss estimation, you can just stick this Pph chart. And this is just to inform you that this is a California obstetric hemorrhage guidelines. So stage 0, if the blood loss is what every doctor can assess what is active management. Third stage should be done in stage 0, stage 1. According to the blood loss, they have done some protocols. And as this Pph previous chart is there, here they have modified the treatment. Means according to the stage 1 is you have to activate the hemorrhage protocol, initiate the preparations, and give the uterotonics. So according to the blood loss, they have modulated and modified the charts. And we always discuss about the bundle approach in Pph. I think the Dr. Poonam will be talking of 0 Pph, and I think she will be touching on this line. I just want to highlight that whenever we talk of Pph, we should have a comprehensive approach at the management of Pph, which consider all areas from the roots to roof and all aspects which may lead to Pph unless taken care. So it includes the preventive and curative both aspects. So right from Amstel, call for help, then there are supportive measures like we have to treat the trauma, and then refractory Pph interventions like compression, balloon tamponade, anti-shock garment, and the supportive treatment like transfusion, referral, and surgery. So one has to have leadership qualities. Whenever there is a Pph, we call for help, and there a whole scenario in that labor room we can just imagine. So one has to be leader, one has to follow, and there should be others should be assistant. So we have to do data monitoring and quality improvement, and we should have the Pph drills in our hospital every time, so that we don't forget. There should be facility readiness, then network integration. You should have a collaboration for the tertiary hospital. These all teamwork and communications definitely helps in management of Pph. So in Pph also we talk of Pph triage, which provides an appropriate environment for the assessment and management of all Pph cases for immediate management. Also, it also should have a local.
We are letting short of time, ma'am.
Yeah, I am finishing. This is the last slide, and it codes the patient as per her severity. Okay, so thank you, and this is what he says. Professor Jerker says that implementing this approach for addressing Pph requires facility readiness, supply chain improvement, teamwork and communication, and network integration. So thank you for the patient hearing, and I think Pph is such a vast subject that it is not possible to cover in 15 minutes all the aspects of Pph, but I could just touch upon some of them. Thank you. All is well. That ends well, and thank you very much for the patient hearing. Thank you very much.
Thank you, madam, for very elaborated and very wonderful talk. So may I request our chairpersons, Dr. Pratik sir, kindly sum up the session.
Thank you, Dr. Vidya Thobi, for that fantastic oration covering so many different aspects of obstetric hemorrhage, starting right from the golden hour, the Pph conditions that we should all be aware of, how to take care of Pph in a systematic, methodical fashion, and also the most recent updated developments, including the use of carbetocin, which I hope will revolutionize the management of Pph in this country. And last but not least, the importance of identifying traumatic Pph and not just considering that everything is just atonic Pph, because if you do that, you can end up losing a lot of patients. So thank you again for this wonderful overview. I know it was very difficult to cover everything in one single shot, but I think you did a fantastic job. Thank you again to Dr. Archana Verma, the entire West UP ISOBAP team, including Dr. Archana Sharma, Dr. Reenu Goyal, Dr. Seema Varshne for inviting me here. It's always wonderful to be in your presence. I get to learn so many things and I meet so many new people every time. Thank you again for inviting me.
Thank you. Thank you very much. Thank you, everyone. Thank you, chairpersons. Thank you.
Thank you, Dr.
Excellent talk, Dr. Vidya. Thank you.
Thank you. Thank you, Krishna Kumari. Thank you, Dr. Pratik. Thank you.
Really, thank you, Dr. Pratik and Dr. Vidya, for many, many more future association with Kasoga president. So we will be doing wonderful job. And one whole talk with you, Dr. Vidya, Thobi, abhi dil bhara nahi.
Thank you, Chairperson.
Thank you very much.
Valuable inputs. So now I invite Dr. Alka Kriplani ma'am, Dr. Usha Sharma ma'am, Dr. Krishna Kumari ma'am, and Dr. Archana Verma to felicitate our two stalwarts, our two budding stars, Dr. Niharika Malhotra and Dr. Neha Gupta, for felicitation of very wonderful, excellent e-newsletter in the last month CME. So may I have the CV, please? May I have the slide, please? Okay.
Yes.
So many, many congratulations, and Dr. Archana ma'am and Dr. Alka Kriplani ma'am, please.
And Dr. Usha Sharma madam is here. I think the kids will feel very, they are not
What's
kids,
happened to the video? I don't know. I'm trying to, yeah, I think.
Raji, please help, please help.
Please help कि video को जो है सो आप on कर दें, please.
Please make her co-host. Yes, sir. Yes, ma'am.
Actually, these two young budding stars are our that main editors, and they have made West UP ISOPERB visible at all platforms with their newsletters. And what a great and fantastic newsletter! We really appreciate your work, Dr. Niharika, especially for writing 3 newsletters. And the last one in emergency was made by Neha Gupta, and it was also fantabulous. So, madam, these people need your blessings, Dr. Usha Sharma, madam, and Dr. Krishna Kumari, madam.
Now, can I say something
Yes.
about Dr. Niharika Malhotra?
Yes,
She has a great legacy to carry on, and I'm sure that she is going to add feathers to it. That is all I have to say.
Thank you so much, ma'am. Thank you.
Dr. Neha Gupta, it was very nice, your letter, and keep progressing. You are, these young people are the future of ISOPARB, or rather any organization. We are only too happy to encourage you and see you in the organization.
Thank you, ma'am.
Congratulations, Dr. Niharika and Dr. Neha. I think it's wonderful to see the young brigade taking over and doing such wonderful jobs. Wish you all the best for future, and we hope to see many more such updates and many more such journals from both of you, and good luck to both of you.
Thank you, ma'am. And I would like to say something here. I am feeling truly humbled and grateful, and all thanks to Archana Verma ma'am. Since I became the Joint Secretary of FOXI, Archana ma'am has actually guided me through this journey and has given me lots of opportunities to actually come out of my shell and, you know, present you different aspects. And learning to make a newsletter also I've learned from her. So thank you, Archana ma'am. Special thanks to Krishna Kumari madam and Usha madam for all the blessings today. Thank you. Thank you so much.
Dr. Neha, you also say a few words.
Thank you, ma'am. Indeed, I am blessed to have great mentors. Ma'am, you have been a very big mentor to me. Literally, you have held my finger and you have guided me how to organize a webinar or everything from writing a newsletter. Every kind of motivation, help encouragement, everything you have provided me. Thank you so much for pushing me forward. Thank you, ma'am. I hope that I am able to do justice to whatever talent you see in me. Thank you, ma'am. Thank you so much.
Thank you.
Thank you all, seniors.
Yes, these two young talented stars, they are really, they are like a media. And you know, you have a great newsletter for your society or your chapter, you are present everywhere. That is a mainstay. So we are really thankful to you. And first newsletter was made exactly within 3 days when I called Niharika, just make newsletter. You know that we have to present the newsletter also. She said, oh my God, madam, there is no time. I go, what is time? इतना सारा टाइम लगता है, एक स्लाइड बनाने में कितना टाइम लगेगा? Just make अभी बनाओ. So then she really made in 2 days only. I gave her 3 days time and she made in 2 days. That was highly appreciable. And all of you can make. I think I really say keep asking and keep joining and make newsletters and start writing papers also. Because अपन तो बहुत old generation हो गए, and all you people, you can do wonders, and we want our team to be at help of the affair everywhere. Whenever I go, I must say very proud, hey, yes, these are our team. I belong to them. So thank you very much.
Thank you all the dignitaries, and congratulations again, Dr. Neha and Dr. Niharika. So now we proceed further in our academic session. So I invite very sweet, very hardworking, our Joint Secretary West UP ISOPAP, Dr. Rashmi Sharma, to kindly proceed for the second topic. Dr. Rashmi, are you there?
Yes, ma'am. Thank you, ma'am. Thank you so much. Good evening, one and all. I'm Dr. Rashmi, and we obstetricians keep on working day in and out to make this world a zero PPH world. So better preparedness is the key to success. So let's unlock that key. So let's unlock that with the key of knowledge shared by our learned speaker, Dr. Poonam Verma, ma'am. Topic is moving towards the zero PPH world. And to chair the session, I would like to invite very charming and the rising star of Foxy, Dr. Neha Gupta. And she has done her MBBS in MD from MAMC, and she did fellowship in minimal access surgery from Wales. And she's the achiever of many awards, and she has held many posts in Noida Obs and Gynae Society. And my second chairperson is Dr. Preeti Vaishya, ma'am. She's very polite and majestic, and she's the president of Bareilly Obs and Gynae Society. We welcome you, ma'am. So now I request Dr. Preeti ma'am to kindly introduce our speaker, Dr. Poonam ma'am.
Hello.
Yes,
hello.
Ma'am. Yes, ma'am.
Hello, good evening, everyone. It's my pleasure to invite all the eminent guests and speakers who have spared their valuable time. I invite Dr. Poonam Verma, who is professor and head of Obs and Gynae Society, Sevagram, Wardha. She has advanced training in SHRH from Uppsala University, Sweden. She has advanced training for Obs and Gynae SDU, ICU, Foundation, Columbia. Clinical skill in trainers training for EMOC, VMC Vellore. Core member of PPH Working Group FIGO. She is President SWOGS. Principal Investigator for E-Partogram, JDF, Skill Birth and Prevailing Birth Defects Project WHO. She is TAG member of including India, and she is recipient of many awards as Doctor's Award for Management of Anemia. She is great oration on RMG and Ideal. I welcome Dr. Poonam Verma. Thank you, ma'am.
Thank you so much, ma'am, for the introduction. Thank you, Dr. Archana, for inviting me for this particular, very interesting webinar on postpartum hemorrhage. I'll just take a second for sharing my slides. So is my slide visible?
Yes, ma'am. It's visible.
I'll try to make it on slideshow, but many a times when you put it on slideshow, it does not work. So please tell me in case my slide does not move.
Okay, ma'am.
So a very warm welcome from MGIMS.
Ma'am, sorry to interrupt, ma'am.
Yeah.
The slideshow is not seen, ma'am, so that you can stop share and share again, ma'am. That will work.
Okay. So stop share
Yes, ma'am.
and share again.
Yes, ma'am.
Does it?
No, ma'am. Ma'am, you are clicking some icon in the share screen, ma'am. Can you please stop share, ma'am? Once again. Yeah. Please click the green color share screen, ma'am.
Yeah, it's share screen, green
yes,
color arrow.
Yes, ma'am. Don't click any of the icon, ma'am, from the dialog box. Please click on the blue color share alone.
Yeah.
Yes, ma'am. Perfect, ma'am.
Can you see now?
Yes, ma'am.
Yeah, and is it moving?
Yes, ma'am. It's moving also.
Okay, all right. So a very good evening to ladies and gentlemen who are there today to hear about PPH as a nightmare. And what a wonderful talk of Dr. Vidya that she's covered most of it, probably which we can even think of. Today, what I am going to talk to you is about how do we move towards zero PPH world, and is it possible? So I bring greetings from Mahatma Gandhi Institute of Medical Sciences, an institute which is still known for its community service and ethics. And with that, also that we give here to our rural women the same treatment which a rich woman will get in the corporate hospital. We believe in respectful maternity care, which is the need of the hour, and we have been trying effortlessly, doing every day some kind of innovations which gives the best treatment to our rural women as well. Friends, we know that we've been talking about the quantitative loss of the blood and accordingly, classifying the women into PPH, but I personally feel that the clinical definition of any bleeding from birth of a rate or amount that has the potential to deteriorate the condition of mother and cause hemodynamic instability and shock is the very useful definition for PPH. Why? Because in the rural area where women loses even 200 ml of blood and goes in shock, that's very, very important. Pam has already said that we have these 4 causes, so I'm not going to go in details. I think we all have completely known this since ages that tone, trauma, tissue thrombin are the 4 important causes of PPH. We also know that when we talk about the pie chart, we know that hemorrhage still remains, and we would be very happy to tell you that if you look into the SRS survey and you look into the most recent maternal mortality rate, India has done so well that we have come down to 103. And you will be very happy to know that Kerala remaining the first with 30 and Maharashtra being the second, 38. And we've been discussing that why Maharashtra has done well. And I'm going to tell you what changes we have made when it comes on to it. So friends, do PPH cases, or when we talk about PPH cases, can we have zero PPH? Is it possible that we will not have PPH? Answer is no. And why? Because there is something called limitation in prevention in obstetrics. Obstetric complications are bound to happen. Teaching and training will keep coming. There will be trainees and there will be difficulties. There will be trainees who will do the mistakes, and in being in medical colleges, one knows how you have to cover up them. Universal protocols are never being followed anywhere. Someone gives different doses of oxytocin, some gives different doses of tranexamic acid, and so on. There are constraints of human resources because we all know this is something which we have been struggling day in and day out, and medical colleges, district hospitals are suffering because of this. So there are bound to PPH happen. There's non-availability of consumables and drugs. So if you go to PHC, then CHCs, you will find that a time will come when suddenly oxytocin is not there. A time comes when methogen is not available. There are plenty of equipments which are not available, and so on and so forth. Still, the skills of doctor is a concern because we many a times know that the doctors and their attitude changes completely when it comes to obstetric emergencies, and the skills somewhere disappear, or if even they are there, because of the stress, they are not used. Delays, as madam has very clearly said, delay 1, 2, and 3 still prevails. When we come on to delay 1, awareness is very poor. The poverty is so much that one does not really get financial aids to come to the hospitals at right time. Transportation is an issue. And a very interesting thing is that even if she reaches a hospital, she's shifted from one hospital to another hospital, and by the time she reaches to a right hospital, she's already dead. Women is still considered as commodity. Her rights are never respected. So even if she has to reach on time, there are nth number of delays done by the family or by the other reasons, and she's never respected for her right. There are plenty of cultural issues, and you will be shocked to see that we have been working in a very interior area, which is called Melghat, which is in CNN as a black spot in India, that maximum maternal death and malnutrition is there. And we realize that the women will die of PPH, and they will keep on calling some Bhoga Baba. They will keep on doing those stupid things. And when she is dead, then they will bring her to the hospital saying that, can you save her now? And there are so many issues. So we very categorically say that zero PPH can never happen. PPH has to be there. It is an entity. It is an obstetric complication, and it will be there. But can we have zero PPH death, and can we move in the world towards zero PPH death? And answer is yes. And why it is yes? Because most of the PPH deaths are preventable. We can evaluate the etiological causes from root to roof, that means right from the patient's home till the tertiary hospitals. Delays have to be taken care of, which we are not really taking care of. We only look into the clinical component, and we never look into the non-clinical component, which has to be focused on. System integration and facility readiness is not there, and none of us are aware of it. Many a times, universal evidence-based protocols are not being followed. There's no feedback loop. We can't discuss about our gaps to anybody who can tell us the solution. And we do not really give patient-centered care where we try and understand what are the problems with the patients and their relatives. Quality improvement have come in the big way, but yet we are not ready to do it. And policymaker involvement and advocacy is yet to happen. Although it is happening, Government of India is doing a lot of work. Government, particularly state governments, are really helping us, but yet we need to do more. So friends, let us understand what is the PPH death cycle and where are we. So if we talk about the PPH death cycle and what are the etiological factors, if we stop them, probably we will save the women from dying because of PPH. It begins in adolescence, where a young girl is anemic and we don't treat her. And then it comes on to anemia and inadequate ANC checkups, where the women does not go for antenatal checkup. And friends, I am telling you, this is not in rural area. The semi-urban and urban area, also PPH women are dying. Why? Because the working women keeps on delaying her antenatal checkup unless one day she's found that she's severely anemic, 36 weeks, we give her blood transfusion, but when she delivers, she has PPH. Unawareness, dependence, poverty, illiteracy is going on since ages. No one is respecting women's rights, and so we have come up that women should know what are their rights, and there comes the role of counseling the women during antenatal period and what we call birth preparedness and complication ready. Home deliveries are still there. If you look into several states, 30%, 40% deliveries are still home deliveries. Maharashtra is very lucky because of several the programs of Government of India and Government of Maharashtra. We are 95% institutional delivery and only 5% hospital delivery. And yet you will see that untrained workers are delivering the women. Even in the institutional delivery, there is less human resource, capacity building is not there, skills are not there, so PPH persists. And this is completely preventable if we train them. And then we go on to the equipments, drug consumables. The facilities are never ready. How many facilities do have Pph kits? How many facilities do have emergency kits? How many facilities where you see that all the equipments are there which are desired? Then there is very poor management and very poor referrals is still existing. And you all must be noticing medical colleges, district hospital, even private sector, we getting from different lower facilities the cases which are very, very difficult to manage, because by the time they reach to us, they are already in stage 4 shock. Transportation is still the issue, even though government has said that there are several referral facilities there. There are various ambulances with 108 and 102, but yet the ambulance reaching to a person at right time is an issue. Even if she reaches to the facility where your emergency departments are not ready, either the stretcher is not there or the attendant is not there, or the doctors are not there. By the time doctors come, it's already 20-30 minutes. Multiple referrals are there. She's coming through several facilities and finally she dies. There's no triaging. Very few hospitals have triage. There's no emergency response team. So these two things which can really save the women is not there. So a woman who's bleeding with PPH is sitting outside and the doctors are examining the patient who's in labor and she's 4 centimeter dilated. So triaging helps you a lot when you have to identify which women needs treatment. And hospital emergency response team and the team division, which tells you that, okay, this is my job and I know what I have to do, is not there in many hospitals. And friends, I would like to share you, MGIMS have done this team, emergency response team and team management. We always, our people collect and they divide into in charge, assistant, supplier and the informer. And once you know that these people are 4, they will do their job and without difficulty, you can manage the emergency. And then, of course, there's no universal guidelines we are following. So if we look into this particular flow chart, we know that every point which I am talking is preventable. And so if we look into these things, we can 100% abort this PPH death cycle and have no PPH death. So what should we do by which we can prevent this preventable death due to PPH? And this is what is called a bundle approach. And we are all going for the bundle approach. So what are these bundles? These are comprehensive approach, which we do when we put all the evidences together, which we have seen after doing a lot of research. Then we develop a strategy about how to manage these cases so as you prevent maternal mortality. And this kind of bundle comprehensive approach should be used in every setting, whether it is a lower setting or a tertiary care hospital, in every country, whether low income or high income, and in urban, semi-urban and rural areas. So basically, it is a universal approach to reduce the case morbidity, case fatality, and overall reduction in maternal near miss and maternal mortality. So friends, 2 trials came up. The first one is Emotive Trial and the second one is Pph Amc Bundle. They came simultaneously, they are ongoing and they are giving very good results. When we talk about Emotive Trial, we are talking about a multi-country clustered randomized trial to evaluate the implementation of early detection and use of WHO first response treatment bundle for reducing Pph. And the Emotive trial has got 3 elements: a strategy for early detection of Pph, first response bundle called Motive, so follow the motive, which is massage, oxytocin drug, tranexamic acid, IV fluid, and examination and escalation. And then implementation strategy, focusing on simulation-based training so that we can look into the various emergency kits and what are their responses. So this is in the journal, it has been published that what they are doing, and the study results are yet to come, and a lot of team are helping them. So it has come in British Medical Journal, so as we can follow these kind of bundles. What I'm going to talk to you is Pph Amc Bundle Approach, which we have done together with 11 medical colleges, and we have seen 0 Pph deaths for nearly 1 year and 8 months until COVID came, and then we saw 3 deaths. So this particular bundle has a clinical part and a non-clinical part, and this bundle is available in online and offline both forms. So when you talk about the clinical bundle, it is just a small card which is with you. Even in the lower setting, if you put it, people can see and do those procedures, and they will be able to save the women. So the first part which I would like to talk about is the active management of 3rd stage of labor, which is universally accepted: oxytocin intramuscular, controlled contraction, and uterine massage. People have changed this AMTSL by putting delayed clamping, cord clamping, and there have been some questions about the massage, but yet it remains one of the very important part of Pph management. And I would also like to tell you that oxytocin has to be replaced in the areas where there is too much of heat by carbetocin, and trials are going on. So prophylactical use of carbetocin is also coming. The second step is that we talk about call for help, because Pph can never be managed alone. We do immediate triaging, and then AB step, we look and exposure, and do a very rapid assessment. As madam has already told, we should go for shock index. Now they are talking about modified shock index, where they take the mean arterial blood pressure instead of systolic blood pressure. And all this is going to make a difference, because our resuscitation team is always an emergency response team, which is multidisciplinary. We come on to the first response bundle, which is ensuring that your uterus is contracted or not and giving massage, giving IV fluid, uterotonic medication and tranexamic acid. And the women trial 2, TRAP 1 and TRAP 2 are coming up in a very big way, which will give us what could be the dose, and can we use much higher dose for cesarean section bleed. Here I would like to emphasize on IV fluid that, friends, we talk about, infusing the woman with the fluid as much as possible, but we have to realize that blood has to be brought much earlier than giving too much of fluid of 2 liter and 3 liter, because this women will either die of pulmonary edema or die of dilutional coagulopathy in case we infuse her with that huge amount of fluid. So one has to be careful. After doing the first response bundle, we have to look for the supportive measure, emptying the bladder, which is a major cause of Pph, ensuring that we repair the tears and whatever vaginal or cervical tears are there, and then ensuring that you do massage and expel out all the clots which are there. Now here question is that some people have a habit of putting their whole hand and removing the clots. Friends, it has been seen that if you do that, you make women more prone for endomyometritis. And so do not try to push your hand inside and empty the clot. Rather, putting a pressure by doing simple massage will expel out your clots much easier. If patient is yet not coming out of PPH, is still bleeding, please go for compression manual mechanical methods before going for any surgery. Your bimanual compression makes a difference. Abdominal aortic compression makes a difference. And I'm telling you, I have shifted my patient who was profusely bleeding, nth number of times such cases are there. You put aortic compression and shift the patient with NASD to operation theater and you will see the difference. The women will be alive and the anesthetist will be able to take care of. Uterine balloon tamponade and ASG are two important things which we recommend very strongly that they are the treatment for refractory PPH bundle before you go for surgery. We have used ESM UBT and in a minute I'm going to share with you. The supportive measures are blood transfusion, transfer the women to high care facility if you do not have facility, and then do all variety of surgical interventions, which Madam has talked about, suturing the lacerations, compression sutures, going for stepwise ligations, going for embolization, hysterectomy, and so on and so forth. And these are some additional clinical practices which the Pph bundle card talks about when you look on the back side. One thing which I strongly recommend are the checklists, and these checklists are going to help you not forgetting anything, because in that chaos, you tend to forget many things. So if you use these checklists, there are several benefits that it improves your teamwork, it establishes very high standard of performance, it rapidly assesses the gap, and so on and so forth. We must talk about non-clinical component in depth, and very quickly I'm going to cover. Madam has shown you this slide, and this particular slide talks about leadership. So whatever you are, your generations coming will be same. If you are not a leader, whatever you would be training others, they will never become a leader. So that's very important. And these are a few things which are very important, in which I give a lot of importance to facility readiness, teamwork and communication, and doing network integration. And I'm telling you in a minute what is it. When you talk about teamwork and communication, we have to have an emergency response team. We have to know how to divide that team. So in charge has some responsibility, assistant has some responsibility, supplier has some responsibility, and informer has some responsibility. So if we go with these responsibilities, you will never create a chaos. And then once you finish your whole scenario with the teamwork, you must have debriefing, which means that when you have, sort of ensure that your patient is stable, please collect together, discuss these things and find out what are your gaps and look into the solution. So the similar things are not repeated in your next scenario. Communication is very important. It could be intra-institutional, inter-institutional, call for help, inviting the emergency response team, communicating to the blood bank, pathology, HDU, ICU, operation theaters, communicating with patient and relative, which is going to lessen your medico-legal issues, and then communicating for transportation team and referral facility. What is facility readiness? You see, facility readiness includes all this. Ensure that you have a PPH kit. Ensure that you have a skilled health workers who know their responsibility. Ensure that you have referral services. Ensure that you have adequate infrastructure where triaging can be done and your HDU ICU is ready. Emergency response team takes over. And then, of course, when you later on want to do quality improvement, everything should be documented and it should be available for data analysis. And these are the problems which we are facing for facility readiness. We do not have a staff. Even if the staff is there, accountability is not there. There are no priorities. Skills of doctors and nurses are not there. Infrastructure is not so good. And there's lack of funding to do all these. So there are some tools like these checklists, which are going to help you what all you should have, indicate what you should have. in the emergency kit what you should have. So those things can be looked at. Now, what is network integration? So we all know that when it comes to PPH, all of us are single team. There should be bi and multi-directional communication, and there should be improved referral, which are going to help us in network integration. And when we say network integration, we're talking about team building, training, and talking. That means giving feedbacks. And then we talk about transferring at right time, tracking whether that patient has gone to a right facility and what happened to her, and thanking. That means that we are obliged to the facility which took care of the patient, and also obliged to the facility which referred the patient at right time. So referral in, referral out checklists are there, which we all need to follow. So friends, we have to improve the quality of care, and unless we reflect back, we cannot plan forward. So we have to see our data analysis and try and find out what is going wrong where. Once we know that, then only we can use this data to form an action, and this is how the bundle has come up. Why? Because even if your facility has highest modality of treatment, something like uterine artery embolization, but the patient does not reach to you on right time, what are you going to do and how are you going to save this women? So please look into these non-technical and technical aspects, both, and then save the women from. In a minute, I'm going to share that this is the man who has changed our world, Dr. Thomas Burke, who came with ESM UBT. Then he went on to the bundle along with Dr. Yarkar. And then we came up with this in Cali, Colombia, that every year they have improved. And now you would be surprised to know that there's an obstetric ICU with 100 beds with 0 maternal death, not even PPH death, but 0 maternal death. And it's known all over the world. Cali, Colombia, Fundación is the place where you have 0 PPH deaths. This is where what we have done in 12 medical colleges. These are our 12 medical colleges where we looked into these kind of non-technical and technical component. We did a lot of workshops at different places. We kept on having meetings, and you will see that every place we have gone, we have propagated this particular bundle, and what wonderful results we have got. We have shared WhatsApp group in which we shared our stories. These are the women who were almost dead, and one of them is one of our staff nurse, and we have saved them from grade 4 shock just by using UBT and NASD, no surgical intervention. We have gone to the PHCs, CHCs, district hospital, and propagated this PPH bundle, and we have found that there is 0 PPH death for 1 year and 8 months, and until COVID came and we had 3 deaths, and now again we do not have PPH. You can see we have gone to PHCs where we have trained ANMs, ASHAs. Doctors have gone for facility readiness, and you can see how they are looking for the suction machine working oxygen, how they are preparing and creating PPH corners. The team has worked for teamwork and communication, where the whole team has been made ready, and the quality improvement workshops have been there where they have made several checklists, debriefing checklists, so on and so forth. And then we have done this advocacy about PPH bundle approach because we know what it has in future. So we've gone to every small place, and we're coming in front of all of you to ensure that we propagate this PPH bundle and all of us can go for this PPH bundle. These have been our successes. We have been able to reduce PPH morbidity to 79.6%. 52% have come with NASG from primary health center. 46% referrals have been from UBT, from primary health and CHCs. Helplines have been really working very well. So these have been our, what you should say, achievements. And now the whole project is running in Uttar Pradesh, Bihar, Jharkhand, where Foxy leader, the chairperson of the Safe Motherhood Committee, Dr. Preeti, has taken over with the help of our Foxy President, Dr. Shanta Kumari, and Secretary Madam, Dr. Madhuri Patel. So this is all going on and we see a great future. So let us put hands together to identify each component which helps in prevention and management of PPH. Let us use this bundle to see what are its effects and create evidences, and then do advocacy and create national guidelines. Thank you so much for your patience here.
Thank you
Thank
so much.
you. Thank you, Dr. Poonam ma'am. You have mesmerized all of us with your wonderful slides, the great content. And yes, I hope that we are able to follow all these bundles, and we really need to have more drills. So, and all the obstetricians should be competent to handle with such situations. And I'm sure Foxy is doing a great job. And with so many organizations like West UP, ISOPAB, where we have such leaders and everyone is taking up these important topics, I'm sure we would reach one day where we will have zero PPH.
Thank you so much.
Thank you so much, ma'am, for such a brilliant talk and covering all the relevant points and sharing all the work done by you all in making the India a zero PPH country. Thank you so much, ma'am, and the chairpersons.
Thank you so much.
Now I hand over the mic to Dr. Kanchan Prasad for further proceeding.
I think you like
Kanchanji, I'm here.
Dr. Preeti Vash also to say a few words.
Yeah.
Thank you.
Dr. Preeti, kindly say a few words.
Hello, ma'am, Dr. Poonam. Very excellent talk for zero PPH. We are expecting that we should be a stage at zero PPH. Thank you so much, Dr. Poonam.
Thank you.
Thank you so much, Preeti Vash ma'am. Thank you so much, Rashmi ma'am.
Thank you.
And now moving on to the next topic, the medical legal aspect. And if we talk about medical legal aspect, it is one of the most important aspect of any obs and gynae practice. And as far as PPH is concerned, obviously we will have to keep in mind, because PPH comes with morbidity and mortality. So the next talk will be delivered by Dr. Ajay Mane sir, and to introduce them, I would like to invite our chairperson of the session. Can I have the CV, please? Yeah, our first chairperson is Dr. Rashmi Sharma ma'am. Ma'am is obstetrician and gynecologist, director Shiv Krishna Hospital, and she is currently joint secretary of West UP chapter of ISOPAB. I welcome you, ma'am. And our next chairperson is Dr. Ruchika Garg. She is professor in the Department of Obstetrics and Gynae, SN Medical College, Agra, joint editor, Journal of Suffolk, and editorial board member, Journal Midlife Health, JK Sciences. And Dr. Ruchika Garg has many awards to her credit, and she is postgraduate and MBBS examiner. I welcome you, Dr. Ruchika Garg, on the board.
Okay.
And now I would request Dr. Ruchika Garg to kindly introduce our speaker.
So I have the pleasure of inviting Dr. Ajay Mane sir. Sir is known for his medico-legal consultant, and we are so much fond of hearing him. So he has so many accolades to his credit. He is the member of National Inspection Monitoring Committee, PCPNDT wing, Government of India of Foxy, and he has been the past chairperson of Foxy Sexual Medicine Committee, Adolescent Health Committee, and he's also been the past president of Aurangabad Obs Gynae Society. So I won't come between you and this speaker. So welcome, Ajay Mane sir.
Yes, thank you, Ruchika madam. Thank you very much, and thank you, Kanchanji, for that kind words. So I'll start. The two batsmen has given 2 centuries, and I'm third number batsman, so I am under pressure to perform well. As Vidya ma'am and the speaker, they have given a good start, basically. Poonam madam, I'll make it a okay. Just a minute. Fine. Two routine questions. Is it seen and am I heard?
Yes.
Yes, sir, you
Yes.
are audible.
Yes, thank you. Thank you very much. Today's topic is given to me by Archana ma'am. It's a medical legal aspect of PPH, and Archana madam ordered me, Jay, you have to speak on this topic in my webinar. Like, yes, madam. I'm her obedient student, so I need to follow the order. Okay. My gratitude to Archana Verma ma'am, who is VP of Foxy and President West UP Chapter ISOPAP, and very good person, a human being, down to earth personality, and ever charming. Thank you, madam. Then Dr. Seema Varshna madam, Secretary ISOPAP, Dr. Renu Goel ma'am, Treasurer ISOPAP, Dr. Rashmi Sharma, Joint Secretary, Professor Dr. Ruchika Garg, West UP Chapter ISOPAP, and the MOC Kanchanji. So I will be telling two situations where the doctor is alleged with the charges and one doctor found guilty, second doctor not found guilty. I'll be explaining the situations. So according to you, there is one situation that a patient had undergone PPH and the patient had been shifted to a higher center, and something given, something not given, services not given, treatment not given. In hurry to shift the patient, हमारी जिम्मेदारी नहीं, इसको झटको जल्दी से. Likewise, the situation was there, and the court found following things. What it is a submission of the learned counsel for the complainant and respondent who has lodged the case, that I have not given the details of the case, the discharge summary, such as not making arrangement of secure blood, not taking advice from other doctors. These are two allegations then available at Kangyang that place. The third one is that not providing ambulance for making arrangement to take the patient in ambulance and with the assistant of medical attendant. These are the four allegations. They were proved correct. Why? Because making arrangement of secure blood is a responsibility of the hospital. Whenever the patient gets admitted, you need to be anticipating the situation, because every pregnant patient is a time bomb. It may explode at any moment. So you must be in anticipation that this woman will go this way or this woman will go this way. So you must be ready for both ways. That's why Poonam madam told the protocols. You be ready with the protocols, have proper drills, have a regular practice of the protocols. And if you follow the protocols, see, complications are bound to be there. If someone says that I don't face complications, my hospital is complication free, then either he or she is telling lies or he or she is not practicing. Basically, if you practice, complications are bound to be there. So having a complication, having a PPH, not a negligence, but not dealing properly with the situation, not treating patient properly, not diagnosing the patient and treating the patient at proper time within proper period is a negligence, basically. Okay, so just keep on treating the patient as a prudent doctor would do, means a general doctor would do, and you are free of litigation. Don't worry. In this situation, they did not make the arrangement to secure blood, then did not provide the ambulance. Providing ambulance is also a duty of the doctor or the hospital to shift the patient in emergency also and in routine also. Okay, and so there should be someone, assistant or accompanying person with the patient till the patient reaches to the higher center or whatever the center they have been referred. Here, what court found, whereas her attempt was only to shift the patient without any facility to erode, and that act itself would prove not only the negligence but also the deficiency in services. They are both not same. They are two allegations. Deficiency services is different and negligence is different. Negligence is more severe. Deficiency of services is milder. Okay. See the situation. She has not given services properly. Opposite party failed in her duty to make preparations, secure blood, and what they have explained to the court is not accepted by the court. What they said, no anesthetic was available, so we did not operate. And the opposite party, see, nowadays everybody is very clever. The Google uncle and auntie is there to help them. All the advocates are there to help them, because there is one trend came from Europe and America. What is the trend? No win, no fees basis. What is that? If the case is lost, then the advocate will not get any fees. And if the case is won by the advocate, then certain percentage will be given to that advocate. And the patient says, okay, there is no harm or there is no loss if I lose, and if I win, I'll get something and the adopter will get something. And this trend has come from Europe and Americans. This is very dangerous trend. So the provocation will be there in certain cases, and doctors are at problem in certain cases. Okay. So in this case, no anesthetic was available said by that, but the other party advocate found that there were two patients underwent elective cesarean operations to deliver on the same evening, for which anesthetic is a must, because without anesthesia, nobody is performing cesarean section, and underwent the elective cesarean section. It was planned. So anesthetic was there. So no anesthetic was available. The sentence given by the consultant was found false. So the court take cognizance of that. Then non-availability of anesthetists to perform other surgical measures at Kangam was a false, basically. Then she has not taken any step to secure blood or taken any effective step to secure blood elsewhere. Making arrangement nearby would suggest that she was continuing the medical negligence during the relevant period. Since postpartum hemorrhage is an inherent risk to be anticipated, said by court, we should take. Then she shifted the patient 5 feet. Nobody was there. Her husband took her in a car to Erode, and within 5 minutes, the departure, blood shot up in the IV fluid, because many times it comes back with a negative pressure. And again, the husband came to the hospital and showed that the blood is coming. So necessitating to bring back the patient to the opposite party, whereas she removed the IV fluid. In spite of giving an assistant, the doctor removed the IV fluid. The patient who is in PPH, she has taken out the IV fluids and sent them even without IV fluid for the management, and no assistant was given. Under the said circumstances, a prudent doctor should have sent at least a trained nurse who was available in the nursing home. They are always available. We can spare one at any moment. In such situation, we can have a doctor, or the doctor herself would have gone. When a patient was in a critical condition, preference should be given to that patient, making alternative arrangements for the remaining patients who are safe, which the opposite party failed, and this should be construed as medical negligence. This was the final result by the court, and negligence proved. And the conclusion, 5 lakh less than 1 rupees was given to the case, and they have been punished in form of compensation. Okay. Anticipation of PPH, as this hospital was having 3 to 4 deliveries a day. What is the case? Blood should be reserved, at least that should be recorded if blood sent for cross-matching. If you send, anticipate the situation, and for all negative cases, reserve at least 2 points of blood, though required, though not required, book it, cross-match it, and keep it there. If not required, your cross-matching money is waste, but if required, you save the time. Within no minutes, you will get the blood bottles. Okay, don't bring it and keep it here, because once you take out of the refrigerator, they won't take it back, and the blood will be wasting. Okay, so blood to be reserved, at least that should be recorded. If blood sent for cross matching, it should be documented. Documentation is very important, that you have taken mere care to have a blood cross matched and reserved for the patient. So that will prove that you are not negligent. Hemaxil should be given until blood comes. They had stated given, but it was not on discharge card written. So discharge card should be filled, or rather written properly, because it is a legal document. The patient can prove many things depending upon the discharge card. So anesthetic should be available. 2 LSs on the same day, and anesthetic was not available is a contradictory. When contradiction comes on paper, the court always goes from the to the other side. Once you prove that, ambulance should be arranged. Nurse or assistant should be accompanying. Second gynecologist opinion should be taken in this condition, which was not taken. Proper documentation is the key to save our skin. Then she was given charge of negligence. Okay, case number 2, National Consumer Redressal. Then primate delivered by LSCS, PPH after delivery, 5 bottles blood immediately and 5 bottles after obstetric hysterectomy. Okay, they have given all the things given. Then second opinion of gynecologist taken for treatment. Patient discharged home. Patient was saved. And relative alleged of negligence. Again, also this is a routine condition. The court comment on this case that patient was transfused about 10 units of bottles, 5 before the operation, after the operation, but the intractable obstetrical hemorrhage of the patient was unresponsive to all measures, and thus to save the life of the patient, operator number 3 performed an emergency subtotal hysterectomy. Okay, that was the finding. Final result, we do not find any deficiency or negligence in removing the uterus, as it was essential in that condition to save the life of the patient, that is mother. Moreover, as the patient's ovaries had been left intact, she has not lost totally her chance to have another child through available advanced medical techniques like assisted reproductive technology and surrogacy, etc. What is the take-home message from this case? Timely intervention in delivery process. What is the timely intervention? They have given the Hemaxil, they have given the 5 bottles, they have given all the medical line of treatment. Pph was not handled with that. Then they went for the surgical line of treatment. Maybe stepwise devascularization they must have done, not fruitful. So they went for the hysterectomy, that too subtotal hysterectomy. Ovaries were preserved, the cervix was preserved basically, and that was life-saving situation over there, and they have saved the life of the patient. So that was very good move from the doctor. Timely blood transfusion, 10 transfusions, timely taken care of 4 Ts, stone, trauma, tissue, thrombin. Then involved second gynecologist in management. That is again a good thing. Whenever 2 experts are involved in the same situation, they give a same opinion, then the court considers that it is correct. Because I may give opinion in favor of myself, because the second one comes with a fresh mind and he gives the same or she gives the same opinion, then court considers that okay, this was the situation and the first doctor was correct, as second is also saying the same thing. And proper record keeping, all the consents, all the situation, every point is written over the paper, and the paper is maintained and in front of the court according to the protocol. What madam said, protocol, follow the protocol, all protocol, FOXI, ICOG, RCOG, WHO, or FOX's own protocols. If you follow the protocols, we can produce in the court of law. These are my papers and this is the protocol. According to protocol, we have gone there. The result is not within the surgeon or the gynecologist's hands. Okay, every body is different. We are treating same way. Some may respond, some may not respond. So that is not in our hand, but we have to try our level best. We have tried. Response was positive in certain cases, response was negative in certain cases. So we are not negligent in negative cases also. Okay, fine. So that's why the consent carries a very much importance in that. So there are 4 types of consent. Implied consent is what? Patient comes to our OPD, we check the patient, we do not take the signature over there. It is taken for granted the patient is going to be examined by the consultant. That is implied consent, taken for granted. Express consent, we explain the patient, okay, now I am going to do the PV. It is also verbal consent, and the patient agrees and we do the PV, that is express consent. What is informed consent? Every positive and negative aspect of the consent is explained to the patient, and it is in the written format, because patient may be hostile in the court of law. So take it in a written format, take a signature over there, take a left thumb impression of the patient, because they may deny that this signature was not done by me, the patient's signature was done by Dr. Mane afterwards, or the nursing staff of Dr. Mane. But we cannot prove like that, but we can prove that left thumb impression belong to the same fellow. And have another habit. Ask the patient if the patient is educated. Nowadays, everybody 99% is educated. So ask the patient to write the name of the patient below the signature in her, or the witness is male, in his handwriting, because we can prove that the handwriting belongs to him through court, through the handwriting expert. So it automatically proves that the signature belongs to the patient. That's why it is an informed written consent. Unanimous consent is a different one. We are not going into the detail. Consent and COVID-19, now it is a declining course, but we must take the everything from the patient, that I may get infection from other patient, I may get infection from the staff, or I may give the patient infection to all the staffs, and the undertaking is there because it is mandatory. Then the negligence, I told you, Jacob-Mittu case was very nice in favor of doctors, because the Supreme Court said so long as a doctor follows a practice acceptable to the medical profession of that day, he cannot be held liable for negligence merely because a better alternative course or a method of treatment was also available, or simply because a more skilled doctors would not have chosen to follow. A prudent doctor would do is done by a simple doctor. That is not negligence. That is he is saved from the charge of negligence. So according to, I am not going into the detail the negligence. What is the difference between civil negligence and criminal negligence? If the negligence is a milder one, so it becomes a civil negligence. You need to pay the compensation. That's all. And it is a gross negligence. It is a very big negligence. It becomes a criminal negligence. In criminal negligence, you need to give the compensation as well as you will get a imprisonment also. It depends on the court who is the magistrate there. Okay. Then Pph cases are the same like that. Adherent placenta usually diagnosed in antenatal checkups in USG. The USG machine is very good today. Adherent placenta we can diagnose, but in certain situations, patients do come unregistered patient directly for the delivery, and if they are having adherent placenta, because in big hospitals it happens nowadays, small hospitals don't accept the unregistered patient, and in odd hours also, because nobody is there to help a patient get shifting is very difficult task at that moment. So the big hospitals may get, the government hospitals may get such kind of patients. So if accepted, call the previous treating doctor. Rather, this is a tip: do not accept unknown patients. And if accepted, call the previous treating doctor or see the records. And if the records are not available, then mention it on paper, because patient always says that I have not brought the records, and they are lost, rather they are at home and whatnot. So we do not know what has happened, what was the previous diagnosis in antenatal period. So mention it. No previous record shown to us. That sentence will save you, as admission notes are very important, because in which condition the patient is brought to your hospital, in which condition you have admitted the patient is to be written on the admission notes. That is the admission notes. So you are tackling the patient from that. Say it is very important in IUFD. If you get the report of IUFD, you must mention that the patient got admitted with the IUFD. So the bleeding tendencies and other complications took place. So we can prove that it was a previous incidents took place, and due to that, the DIC and all the complications took place, or maybe infection, whatever. But you need to write down proper admission notes. That will save you. Denial is your right, except in life-threatening condition. That is more important. If the patient is settled, you can deny. No, patient is not mine. I cannot accept the patient, and send the patient with the proper documentation, send with the proper referral sheet, because if the patient is in need of primary things, IV fluids or whatnot, you can give primary things, padding and all the things, and then send the patient with the assistant. And if ambulance is arranged, that is a good thing for your side. Okay. Tips: life of patient is important, so uterus can be swaha kar sakte hai usko. If placenta and part is kept inside, then mention everything on paper. इनक्रीटा है, परक्रीटा है, आपको उसको अंदर रखना तो बहुत जरूरी है, निकाल नहीं सकते उसको, आप मेंशन करो उसको। आप बहुत ज्यादा ब्लीडिंग हो रहा है, लिवर लैक्सेशंस है, या यूट्रस की वजह से बहुत ज्यादा उजिंग हो रहा है, आप कुछ नहीं कर सकते, उसके लिए आपने मॉप रखा है अंदर। सो वी हैव डन 2 times, मॉप रखा है। सो राइट इट डाउन कि मॉप रखा है, 2 दिन के बाद में ओपन करके मॉप निकाला, उसमें ब्लीडिंग बंद था, उसमें वो भी ऑपरेशन नोट्स लिखिए कि 2 दिन के बाद मॉप निकाला है। दैट इज एक्सेप्टेड बाय द लॉ, कि आपने पेशेंट की जान बचाने के लिए किया था। इट वाज नॉट फॉरगॉटन, इट वाज इंटेंशनली पुट इनसाइड एंड देन रिमूव्ड आफ्टर मे बी 2 days or 3 days after stopping the bleeding. Advise proper follow-up schedule to the patients and explain importance of the timetable and the steps in it and the consequences of not following the schedule. Document it, everything. If you advise something to patient and patient do not follow that, it is a contributory negligence. What is contributory negligence? It is negligence on the part of patient, and that is beneficial to the doctors, that we can say, okay, this bad result is due to that patient, and that is a contributory negligence. We are not negligence. We have advised, but we are advised on paper. You have to write it down, then and then only it is considered that you have advised. Okay. लिखने की आदत डालिए, कुछ भी आप पेशेंट को बोलेंगे लिखिए। आपका सिंपल सा 2 सेंटेंस, advised patient, patient not listening, patient not taking treatment, patient not coming for regular follow-up, ये आपका इतना सेंटेंस आपको बचा सकता है कि हमने तो बोला था, पेशेंट आया नहीं, हम क्या कर सकते हैं? हम घर पे जाके तो नहीं बुला सकते, वो क्या दामाद और बहू थोड़ी कि जाके आ जाओ घर में ऐसा करेंगे, है ना? तो अपना हमने जिम्मेदारी निभाई है, पेशेंट ने उसकी जिम्मेदारी नहीं निभाई, contributory negligence, we are safe. If patient do not come for follow-up, call or inform them to come नर्सिंग स्टाफ ने ये करना चाहिए, और जो उनको इन्फॉर्म किया या उनको फोन किया इसका भी रिकॉर्ड रखिए. टेक एडवाइस ऑन पेपर ऑफ अनदर एक्सपर्ट से ऑन्कोलॉजिस्ट लाइक नीडेड, और दूसरा ऑब्स्टेट्रिशियन गायनेकोलॉजिस्ट उसका, या पीडियाट्रिक के लिए किसको बुलाए तो वो, या तो फिर अभी कार्डियोथोरेसिक सर्जन भी आ सकते हैं, बहुत ज्यादा ब्लीडिंग हो रही है उसमें तो, या तो फिर अपने लोग अभी एक्सपर्ट हो गए स्टेप वाइज डीवैस्कुलाइजेशन करने में, या तो कोई एम्बुलेशन करने वाला रेडियोलॉजिस्ट है उसको बुलाया है, वीक सेटअप है, तो उसका भी ओपिनियन आप ऑन पेपर लेके उसका पूरा कर सकते हैं. ठीक है ना? ओके. Either charge against the doctor, then क्या? Obviously there was a mistake, so no point saying that the checklists were correct, but you have to follow the checklist wise, so you can prove that checklist correct थी, हमने ये किया था, we are not at fault. Explaining the relatives in a scientific way, usually they may not be in the mood to listen. वो तो हमेशा रहते हैं, वो तो सुनते नहीं, उनको लगता है हमेशा डॉक्टर की गलती है. ठीक है. अब इसमें थर्ड एक है कि आउट ऑफ कोर्ट सेटलमेंट कैन बी डन. आपकी गलती है, मान लो पीपीएच में पेशेंट गया है, आपने उसका करने का बजाय आपका डायग्नोस नहीं हुआ, पेशेंट शिफ्ट कर दिया लेबर से रिकवरी रूम में, एंड आपके सिस्टम ने देखा नहीं, बहुत ज्यादा ब्लीडिंग हो गया, पेशेंट सकम हो गया, उसमें आपकी गलती दिख रही है, तो उसमें आप आउट ऑफ कोर्ट सेटलमेंट कर सकते हैं. अब आउट ऑफ कोर्ट सेटलमेंट मींस आप केबिन में बुला के उसको 2 लाख रुपए दे देंगे, बाद में वो 2 महीने बाद फिर से आके फिर से पैसे मांगे. दैट इज नॉट आउट ऑफ कोर्ट सेटलमेंट. उसके लिए आपको एक डिस्ट्रिक्ट लेवल पे कमिटी रहती है, दैट इज कॉल्ड एज लोक अदालत, वेयर अ रिटायर्ड डिस्ट्रिक्ट जज इज देयर. उनके सामने आपने आपकी साइड बोलनी है, पूरा प्लीडिंग करना है. पेशेंट विल कम, ही विल से व्हाटएवर यू वांट टू से और शी वांट टू से इफ शी इज अलाइव. उसमें कॉम्पेंसेशन डिसाइड करेगा कोर्ट, एंड कोर्ट के थ्रू पैसे भरेंगे. आप कोर्ट में पैसे भरेंगे, कोर्ट उनको पैसे देगा, एंड वहां पे एक आपका डिक्री बोलते हैं उसको, इट इज अ स्टेटमेंट और इज अ रिजल्ट ऑफ कोर्ट. एंड आफ्टर दैट वो आपको दुनिया के कोई भी कोर्ट में केस नहीं कर सकता, बाद में आपको आके पैसे भी नहीं मांग सकता, क्योंकि कोर्ट के थ्रू उसको कॉम्पेंसेशन मिल चुका है. दैट इज द बेस्ट ऑप्शन इफ यू आर एट फॉल्ट. ओके. ज्यादा ईगो करने की जरूरत नहीं. हम समझ सकते हैं कि इसमें चलो मेरी थोड़ी सी गलती हो गई है या मेरे स्टाफ की गलती हो गई, मेरी मींस नॉट नेसेसरी है इस टाइम यू आर एट फॉल्ट. आपके स्टाफ की भी गलती है तो दैट इज अ विकैरियस लायबिलिटी. आप ओनर हो, आप ट्रीटिंग डॉक्टर हो, तो विकैरियस लायबिलिटी लाइज टू यू. सिविल लायबिलिटी है, क्रिमिनल लायबिलिटी आपके ऊपर नहीं आती. अगर स्टाफ की गलत इंजेक्शन से पेशेंट मर गया तो स्टाफ पे केस होगा, आपके ऊपर विकैरियस लायबिलिटी. क्रिमिनल की नहीं आती, कॉम्पेंसेशन आपको देना पड़ेगा. इसलिए हैव अ इंडेमनिटी ऑफ स्ट्रॉन्ग. कितना इंडेमनिटी होना चाहिए? कम से कम 1 करोड़ का होना चाहिए. आजकल पेशेंट लाख में मांगते नहीं, करोड़ में ही मांगते हैं. अभी डिस्ट्रिक्ट लेवल 20 लाख का था, 1 करोड़ कर दिया था उन्होंने, फिर अभी वो उन्होंने फिर से 50 लाख से 2 करोड़ तक लाया है डिस्ट्रिक्ट लेवल का, और स्टेट का जो है 2 से 10 का और नेशनल का 10 के आगे, ऐसा किया है उन्होंने. ठीक है. तो इंडेमनिटी स्ट्रांग होनी चाहिए, 2-3 इंसिडेंट्स का होना चाहिए, और सबसे मेन इंडेमनिटी में आपका स्टाफ भी कवर होना चाहिए. आप जब साइन करते हो इंडेमनिटी तब जरा ध्यान से पढ़िए. वो आती है मैडम यहाँ साइन कीजिए, हम हाँ कहाँ साइन करना, यहाँ पे हाँ साइन करके दे देते. ऐसा मत कीजिए. उनको बोलना शाम को मुझे पढ़ने दे, या तो मुझे समझा क्या क्या है इसमें प्रोविजंस. उनको 3 चीजें पूछनी है. 2-3 इंसिडेंट्स का इसमें कवर है, बता कहाँ लिखा है. मेरा स्टाफ इसमें कवर है, बता कहाँ लिखा है ना, और कितने का है. 1 करोड़ से ज्यादा का होना चाहिए. ओके. तो सेक्शन 304A, देयर आर 2 सेक्शन, 304 और 304A. 304A कहता है कि द डेथ इज बाय नेग्लिजेंस, मतलब 2 साल की ज्यादा सजा हो सकती है. 304A कल्पेबल होमिसाइड, अनइंटेंशनल मर्डर में जाता है, उसमें 7 साल तक की सजा हो सकती है. डिफेंस ऑफ अ डॉक्टर मैंने आपको बोला क्या है. प्रिकॉशंस अगेंस्ट नेग्लिजेंस इन पीपीएच केसेस, ऑब्टेन रिटन इन्फॉर्म कंसेंट ऑफ द पेशेंट एवरी टाइम patient is not in condition to give the consent, then have a consent of relatives. It is allowed for good faith. The relative can give consent. वो सेक्शन नंबर नहीं बताता मैं आपको, पर पेशेंट का रिलेटिव दे सकता है. इमरजेंसी में आप उसका वर्बल कंसेंट भी ले सकते हैं, वीडियो कंसेंट भी ले सकते हैं. कैमरा ऑन कीजिए, मोबाइल का कैमरा कीजिए, सीसीटीवी का कैमरा कीजिए, उसमें आप रिकॉर्ड कर सकते हैं आपने क्या क्या समझा है उसको, एंड आप कर सकते हैं. उसमें आपको रिटर्न की भी जरूरत नहीं है ना. सिर्फ एमटीपी, पीसीपीएनडीटी एंड ऑर्गन ट्रांसप्लांट में ही आपको मैंडेटरी है कि आपको रिटर्न कंसेंट लेनी पड़ेगी. बाकी आप ओरल या वर्बल कंसेंट ले सकते हैं, पर पेशेंट डिनाई करते हैं इसलिए हम उसमें रिटर्न कंसेंट देते हैं. यहाँ आप वीडियो कंसेंट ले सकते हैं. वीडियो कंसेंट इज वैलिड, इट इज एक्सेप्टेड बाय द कोर्ट. डेवलप गुड रैपो विद द पेशेंट एंड रिलेटिव. उनके साथ बात कीजिए थोड़ा बहुत, तो क्योंकि हम लोग बहुत बिजी रहते हैं. कितने पेशेंट है? 30 पेशेंट है, 30 पेशेंट देखने हैं मुझे, तो हम बात नहीं कर सकते उनके साथ में. जो भी पेशेंट इंडोर है उनको सवेरे शाम का राउंड लीजिए, जो हम मेडिकल कॉलेज में करते थे. बहुत सारे कंसल्टेंट मैंने देखे हैं जो प्राइवेट प्रैक्टिस में, सिस्टर राउंड ले लिया, ठीक है, आप खुद जाइए पेशेंट के साथ बात कीजिए. आपका बात करना पेशेंट के लिए मेडिसिन से ज्यादा काम करे. पेशेंट विल बी हैप्पी कि अरे डॉक्टर साहब मैडम आके गए और आई एम यस मैडम अच्छा लग रहा है मुझे, आप कंधे पे हाथ रखिए, चलो उठो मेरे सामने चल के बताओ ये करो, 5 मिनट लगते हैं मैडम, ठीक है ना। अपना कितना रहता है 15 या 20 बेड का हॉस्पिटल है, उतना राउंड बहुत जरूरी है, 1 घंटा उसमें स्पेयर निकालिए, फिर ओपीडी में बैठिए कि फुल एक्यूरेट लेजिबल मेडिकल रिकॉर्ड, ये रिकॉर्ड है जो आपको बचा सकता है। आप जो भी बोलेंगे, जो भी एडवाइस करेंगे, पेशेंट को लिखो, और जो भी आपने लिखा है वही समझा जाएगा कि आपने किया है। जो चीजें आपने उसमें लिखी नहीं है, अरे मैंने तो ये दिया था पेशेंट को, मैंने ये दिया था, वो दिया था, हिमैक्सिल दिया था, आपने लिखा नहीं है। पहले केस में वही था, उन्होंने हिमैक्सिल दिया बोला पर लिखा नहीं है डिस्चार्ज कार्ड में तो लिखा नहीं मतलब नहीं। हमारी केस थी हमारे हॉस्पिटल की, उसमें एक पेशेंट था छोटा बच्चू, अब ये पीपीएच का नहीं था पर छोटा बच्चू था, उसमें पेशेंट रिकवरी में सकम हो गया, वेंटिलेटर पे डाला और वो सब कर रहे थे पीडियाट्रिशियन और सर्जन, पर वो डेथ हो गई पेशेंट। पुलिस आए, पुलिस ने वो पेपर लेके चले गए। Actually, what is the law? Police should write a application to you that kindly hand over the paper and you are having 36 hours to complete the paper. ये लॉ में लिखा हुआ है, पर पुलिस वाले कभी कभी ऐसे लेके जाते हैं, नहीं हमको पेपर अभी चाहिए, आप दे दो उनको पेपर, अगर बहुत ज्यादा इंसिस्ट करते हैं दे दो, पर देते वक्त सबसे नीचे जहां पेपर का आपका इनकम्प्लीट पेपर है, तो जहां आपके एंड खत्म हो गए ये नोट्स, वहां पे नीचे लिखना है कि दिस इज इनकम्प्लीट पेपर. As police has forced to take the paper, we are handing over the incomplete paper. Sign, stamp, वहाँ का टाइम डालिए, डेट डालिए, और जितने भी पेपर आप उनको देंगे उसमें ऊपर नंबर डालिए 1 2 3 4 5 6 7 पेजेस, और उनसे रिसीव्ड लीजिए फोटोकॉपी. ओरिजिनल पेपर देना नहीं है, ओरिजिनल पेपर आपके पास रखिए, उनको फोटोकॉपी दीजिए और उस पे उनकी साइन लीजिए ओरिजिनल पे कि मुझे वो एक फोटोकॉपी मिली इंक्लूडिंग 37 पेजेस लाइकवाइज उसका, तो बीच में एक आधा दूसरा पेपर कहीं मिस ना हो जाए. मिस भी हुआ तो हम बोल सकते हैं कि देखो हमने 37 पेजेस बोले थे, जिसमें 36 पेजेस है, एक पेज गायब. अनइंटेंशनल हो सकता है, इंटेंशनल भी हो सकता है, सो वी हैव टू टेक केयर. हमको हमारी प्रोटेक्शन का बहुत ख्याल रखना जरूरी है. ओके, तो ये करके दीजिए उनको, तो दैट विल सेव. तो वो दे दिया, तो कोर्ट ने हमको पूछा कि आपका तो इनकम्प्लीट है रिकॉर्ड, तो हमको तो वो भी लिखने नहीं दिया पुलिस ने. हमारा जो पीडियाट्रिशियन था उसको वो भी लिखने नहीं दिया कि इट इज इनकम्प्लीट पेपर, तो उसने सिर्फ लाइन मारी थी ऐसे, तो उसने बोला सर वो लिखने भी नहीं दिया, उसने हमें लिखने को बैठा तो पुलिस ने पेपर खींच लिया, तो वो लाइन आ गई है नीचे. सो कोर्ट हैज एक्सेप्टेड दैट बिकॉज द नर्सिंग स्टाफ हैज गिवन द ट्रीटमेंट चार्ट. हमने वो जज साहब को बताया कि सर देखिए नर्सिंग स्टाफ ने ट्रीटमेंट चार्ट दिया है, उसमें हर चीज लिखी है, सोडा वाइकर दिया, एट्रोपिन दिया, एड्रेनालिन दिया, व्हाट नॉट 1 2 3 4 5 6 पूरा पेज 2 पेज भर के उन्होंने ट्रीटमेंट दिया था, और इधर तो नोट्स कुछ भी नहीं थे. डॉक्टर साहब हमने बोला कि देखिए नर्स, ये नर्सिंग स्टाफ इज देयर टू फॉलो द ऑर्डर्स, दे आर नॉट देयर टू गिव ट्रीटमेंट ऑन देयर ओन, दे आर देयर टू फॉलो द ऑर्डर्स. मीन्स कोर्ट ने क्या कंसिडर किया है कि ये जो ऑर्डर नर्सिंग स्टाफ ने लिखा है ये डॉक्टर ने दिया है, उनको पेज कंप्लीट करने को टाइम नहीं मिला, पर नर्सिंग स्टाफ ने लिखा है मतलब दे हैव गिवन द ट्रीटमेंट एंड निग्लिजेंस यहाँ प्रूव नहीं हुआ. आवर हॉस्पिटल हैज एक्विटेड, कुछ भी नहीं हुआ ऐसा. एंड व्हाट इज दिस? डू नॉट गारंटी a success 100%. Of course this is given by some quack bundle BI MS, what is the degree, I don't understand. Here the guarantee that he she will suffer from the same disease, I will give free treatment, ऐसा कोई देता नहीं, पर just out of lighter mode I have given. So PPH can be there, it is not negligence, but not diagnosing the PPH, not treating the PPH in a proper protocol way is a negligence. So उससे बचना है तो प्रॉपर ट्रीटमेंट कीजिए. जो भी आप ट्रीटमेंट करते हो 99% ऑफ अस वी आर ट्रीटिंग इन अ प्रॉपर वे, बट वी आर फेलिंग टू राइट डाउन. सो राइटिंग डाउन इज अ only way to save you from the charges of negligence. So kindly write it down. This is women empowerment in Israel, this is women empowerment in India. Captain Dr. Pph Chetri, gun for nation, state of the unit, and salute. And this is my humble request to all of you. The voting process has been started since yesterday. It is up to 30th of the March. Those who have not voted, kindly vote and kindly promote others to vote. Give me one vote. There are 2 votes for West Zone. Give me 1 vote. Second vote is of your choice. So kindly help me go to Foxy as Vice President. Thank you. Thank you very much, and thank you Archana Verma madam, Dr. Seema Varshney madam, Renu Goyal ma'am, and West UP chapter ISOPAB, and Kanchan ji for the webinar. When they can stay together, why can't we? When they can stay together, the panchi hoke bhi saath mein hai. So help your colleague that only your colleague will help you in your bad situation. Everybody will enjoy your bad situation, but your colleague will come to your place and help you. Thank you. Thank you very much.
Thank you.
Thank you, sir.
Thank you so much, sir. It was very informative and excellent talk, and all the best for your election. And now I would request Rashmi Sharma ma'am to kindly give the concluding remark.
Thank you, Dr. Kanchan. Thank you so much, sir, for sharing such a practical tips and in this giving such a relevant medical legal tips in this era of litigation. So as we know, the Pph is the major cause of maternal mortality. So one should concentrate on the following points. One should not delay the diagnosis, and we should follow the protocols, and we should do the timely intervention, and we should timely communicate with the patients and attendants, and we should deal with the complication as a teamwork. And last but very, very important, documentation is to be done properly. So with this, I'm done. So thank
Correct,
you so
madam.
much.
Yeah, in very few words, she has summarized the lecture. Those are called as golden hours. The golden hours are wasted, patient won't come back. Thank you, Rashmi ma'am. Very, very well summarized.
Thank you so
Thank
much.
you. Thank you so much,
Dr.
Rashmi ma'am.
Ajamani, thank you. You know, everybody, you must remember his name, not only for election, but rather for hospitality. You know, and for Aurangabad and going to Sai Baba's that darshan, he can do anything. He's a boss of that side, you know.
Thank you, madam. Thank you very much. And you all are invited to come to my place, Aurangabad, Verul Ajanta, and Sai Baba, Shirdi Sai Baba is very nearby. Come to this place after this Corona era. Thank you. Thank you very much.
Really good wishes to you. And we need blessings from Sai Baba also, and to you and to all of us.
Yes, ma'am. Thank you very much. Thank you. And thank you, Kanchanji.
Thank you. Thank you so much, Ajay sir. Thank you, Archana ma'am. And for the next session, I would like to hand over the mic to Renu Goyal ma'am. Ma'am.
Hello. Thank you, Dr. Kanchan. Now, fourth topic is obstetric shock by Dr. Archana Sharma ma'am. I am inviting chairperson for this session, Dr. Kanchan Prasad and Dr. Manisha Agrawal. Dr. Kanchan Prasad is champion of Foxy Award 2021. And Dr. Manisha Agrawal, Secretary-elect, Ghaziabad Obs and Gynae Society 2022 and 2023. Welcome both of you. Now I invite Dr. Kanchan to introduce Dr. Archana Sharma ma'am.
Thank you so much, Renu Goyal ma'am. And first of all, I would like to thank Archana Verma ma'am for giving me this opportunity to chair this session. Ma'am is a great mentor and she always encourages us. Thank you so much, ma'am. And Dr. Archana Sharma ma'am, she is so humble and she has so much experience, and she's great friend. And it is my privilege to introduce Archana Sharma ma'am. And ma'am is the currently North Zone Coordinator of Food and Drug Medical Surgical Equipment Committee. And ma'am is the Scientific and Clinical Director, Ganesh Hospital and Test Tube Baby Center, Ghaziabad. And she's past President, Chairperson and Secretary, Ghaziabad OBGYN Society. And ma'am has organized various conferences and various CME in past, and she is a very active and dynamic member of ISOPAB. And she has a special interest, and she's working in the field of ART, infertility, laparoscopic surgery for last 20 years. And ma'am is recipient of Dainik Jagran Ayushman Award 2020 for excellent services in medical field. And her field of interest is fertility enhancing laparoscopic surgery, USG, and ART. I welcome you, ma'am.
Thank you, Dr. Kanchan, for so much nice words. Yes, I am audible. I think so.
Yeah.
Yes.
Yes, ma'am.
Thank you very much, the organizers, especially the guiding force and encouraging our Vice President Foxy and President West UP ISOPAB, Dr. Archana Verma, Madam, for giving me this particular.
Slides, so Archana Sharma, just I can see your slides are 62, but the time is limited, है ना?
हाँ, तो मैं बहुत थोड़ा बोलने वाली हूँ.
Okay, and what a great, wonderful team of this Kanchan and Reenu. मेरे को तो लगने लगा तुम लोग सब बहुत expert हो गए और आराम से ना. Very nice, great going. I am really impressed.
So thank you very much for giving me this opportunity. Seema, Reenu, Dr. Kanchan, Dr. Archana Verma. So now we are going to talk something about the shock. Actually, so much has been discussed about whatever is shock in the PPH. I don't think I need not to tell very much as far as the shock is concerned. So it is defined as, everybody knows, that acute circulatory dysfunction resulting in insufficient oxygen and nutrient delivery.
Slides are moving. Slides.
Yes, slides are moving. And nutrient delivery to the tissues relative to their metabolic demand, reaching to cellular dysfunction that may cause lactic acidosis and later on.
Can you see the slides? The slide is not on the slide share mode and they are not moving.
Okay, then
Put
I
it
have
on
to
slide
stop.
share moment.
Okay.
Archana, you need to stop sharing, do it on slide mode and then share.
अभी ठीक है?
अभी आ रहा मैम. It's no.
नहीं आ रहा है?
Upper left, there is slide share mode. Click there in upper left.
Yeah, it's fine now.
Yeah.
It's fine now.
Yes, ma'am.
अभी ठीक है?
हाँ मैम.
Now we can see at least.
Okay, अभी ठीक है ना?
Yes.
So now I am talking on the obstetric shock. It is defined as an acute circulatory
But why
dysfunction.
everything? My पूरा laptop क्यों दिख रहा है? मतलब only the slides should be visible.
Ma'am, please reshare once again, ma'am.
Ma'am, you can zoom it also perhaps. वहाँ से zoom कीजिए. From the zoom in है. Zoom I mean.
पता नहीं, अभी तो यार ठीक दिख रहा था, उस समय तो बहुत बढ़िया.
PPT मोड आपको zoom और करना पड़ेगा मैम.
यहाँ से शेयर करूं? अभी कुछ बेटर हुआ? अभी आ रहा है?
अभी आ रहा है मैम. अभी आ रहा नहीं.
अभी ठीक है या इसे फर्दर जूम करना पड़ेगा या और कुछ करना पड़ेगा?
जूम करना पड़ेगा मैम. जूम करो. राइट लोअर में जूम का ऑप्शन है. राइट लोअर इन द बार.
यहाँ पे?
हाँ, जूम इट अ बिट.
अभी हुआ?
जूम उसके और राइट में है.
और राइट
यहाँ
में
पे 70, तुम्हारे में 79 लिखा है, उसको थोड़ा सा और जूम करो उधर.
थोड़ा सा उसको 90 अबव कीजिए मैम.
मैं दोबारा इसको शेयर करती हूँ.
Don't click at any icon, ma'am.
No. Now I am sharing.
Okay. It is coming. हाँ, उसको इंक्रीज कीजिए मैम जूम को. ज्यादा हो गया. डिक्रीज इट. लेस देन 100. 90 to 100. मिडिल में देयर इज वन बार. उसके जस्ट नीचे
वही ट्राई कर रही हूँ.
देयर इज वन लाइन स्ट्रेट स्टैंडिंग लाइन.
अभी ठीक है?
ठीक है.
ठीक है.
थोड़ा सा और जूम इन की. थोड़ा आपके वर्ड्स
कंचन में वर्ड्स कट जाएंगे.
हाँ, थोड़ा और कम करने बोल रही हूँ मैम मैं. हाँ, अभी ठीक है.
अभी ठीक है ना? So a shock is defined as an acute circulatory dysfunction resulting in the insufficient oxygen and nutrient delivery to the tissues relative to the metabolic demands, leading to cellular dysfunction, later on causing the cell death. I think it is the most serious accident, that is the obstetric shock, and prompt recognition and management can improve the maternal outcome. So now we have to classify, because people were talking in there about Dr. Archana, थोड़ा सा कुछ अनम्यूट करना पड़ेगा किसी को.
Now she is on mute, ma'am.
Okay, thank you. Now we, since evening, we are talking about the Pph and hemorrhagic shock and so many things. Now there are other shocks also during the obstetrical status of the patient, and that should also be discussed. It can be classified into hypovolemic shock, what we are talking about. Dr. Vidya Thobi has so nicely summarized the whole talk. Then septic shock, cardiogenic shock, distributive shock, and the neurogenic shock. So it can be classified in that way only. And hypovolemic shock, actually, there is a loss of fluid from the circulation, which is an important factor. This is caused by the hemorrhage either from the cut vessels or by the escape of the fluid from the vessel that have become more permeable. So it is a condition of inadequate oxygen perfusion due to the loss of intravascular volume, causing a drop in the cardiac preload to a critical level and reduced macro and micro circulation with negative consequences for the tissue metabolism and triggering of an inflammatory condition. Now coming to the pathophysiology, stage 1 is a compensated. It can be treated with the IV fluid therapy and it is reversible. But in decompensated, there is maximal compensatory mechanisms are acting, but still tissue perfusion is reduced. So vital organ function is also reduced. And third one is irreversible. When vital organ perfusion is badly impaired, so the profound decrease in the perfusion leads to cellular death and organ failure. In between, there occurs the acute tubular necrosis in the kidneys, severe acidosis, and decreased myocardial perfusion. So now we must understand the hemodynamic consideration actually while dealing with the hemorrhagic shock. Because pregnancy itself is a leading cause and reason for the hyperdynamic and hypervolemic maternal circulation. Cardiac output increases, everybody knows. So 30% fluid loss can be tolerated without tachycardia. So in early stage, it may be easily missed unless the blood pressure is taken. A profound degree of shock is always easily recognized, but otherwise it becomes difficult sometimes to recognize the shock in early stages. Aortocaval compression aggravates the instability seen in the hemorrhages, and in the antenatal period, this early stage shock or the uteroplacental hypoperfusion may occur before the maternal signs are evident. Adverse effect on the fetus can be detected by the fetal heart rate abnormalities on the cardiotocograph. No investigation is required because patient is in agony, patient is in problem. We have to start immediately the treatment, and initial management does not depend upon the knowledge of the underlying cause. There is no laboratory test required at that time, only the pulse rate, blood pressure, tachycardia, hemoglobin, BTCT, PT, APTT, coagulation profile, fasting blood sugar, routine and urine analysis will work. And signs of the inadequate perfusion and oxygenation leads to start of the prompt treatment. Now management, as Dr. Vidya has very nicely enumerated, that is a teamwork of anesthetist, obstetrician, physician, and hematologist. A proper drill should be done in the hospital for the acute shock management, and it should be started as soon as it is possible with the prompt restoration of tissue perfusion. Initial management, we have already discussed it, ABC of the resuscitation, insert 2 wide bore cannulas, restore the blood volume, giving crystalloids, colloids, everything, patent airway to be assured, and ventilation should be checked, and if needed, ventilator or anesthesia machine can be used with the intratracheal intubation. That is very important. And we can monitor the response to therapy by monitoring pulse, blood pressure, SpO2, etc., urine output, and pH. And head down in the left lateral tilt to avoid the aortocaval compression, which might worsen the hypotension. Because it is an hypovolemic shock, I think vasoactive drugs have no part in treatment of the hypovolemic shock. If the shock is worsening, then the later stages, we can start the vasopressor or vasoactive drugs or the inotropes. Causes everybody knows, that is the antenatal, intranatal, and postnatal, ruptured ectopic, uterine perforation, incomplete abortion, APH, PPH, uterine rupture, inversion, thrombosis. There are so many things. Apart from the PPH, there are other causes also, retained tissues or POCs. Then there may be sometimes a non-hemorrhagic shock, like because of the hyperemesis gravidorum in first trimester of the pregnancy. There may be excessive diarrhea that may also lead the patient to cause a hypovolemic shock. Management is again, along with the resuscitation, we must do the diagnosis of the underlying cause and definitive treatment. Any obstetrical or surgical treatment, whatever is required, like in ectopic pregnancy, surgery, DNC, if perforation is there, laparotomy, if there is inversion of uterus or PPH, we have already discussed the whole treatment in very detail by Dr. Vidya. The other shock advances in the shock management is a salvaged cell transfusion, in which blood is removed from the operative site through the hyperinized suction tubing and a filter collecting reservoir and processed by washing and centrifugation to remove the contaminating debris. Resulting RBCs have an hematocrit of 55 to 80% and can be returned to the patient quickly. But traditionally, cell salvage is avoided in the obstetrical population due to perceived risk of amniotic fluid embolism or induction of the maternal alloimmunization. It is a cost-effective treatment with high rates of transfusion, but requires a maintenance cost. So much training to the staff is required, and it is not used in the cases of PPH as the blood may be contaminated with the feces and the urine. Now, second is the transfusion of the recombinant activated factor 7, which forms a complex with the tissue factor, a key initiator in the hemostasis, leading to the production of a small amount of the thrombin, and activating factor 5, 7, and platelet aggregation at the site of injury. Hence, aids in the conversion of fibrinogen to the fibrin and formation of the clot. There are several reports documented for the effectiveness of controlling postoperative bleeding. Third is again, pelvic arterial embolization can be performed under the moderate sedation, and there is an avoidance of the surgical risk. Now, coming to the second very important variety of shock, that is the septic shock. It is having very high mortality rate, and maternal mortality rate of the septic shock is around 3% or sometimes more than that. It also complicates the pregnancy by increasing the rate of preterm labor and fetal infection and the preterm delivery. So coming to the predisposing factors, there may be post-vaginal delivery endometritis or post-LSCH endometritis, may be infected RPOCs after DNC or inside aseptic abortions, sometimes uterine perforation, peritonitis, water birth delivery, then premature rupture of membranes, and anyhow by mistake if cervical encerclage has been performed in the premature rupture of membrane cases, then pregnancy with retained IUCTs, intraamniotic infections, chorioamnionitis, and some other reasons when infection is outside the uterus, that may be pyelonephritis, pre-existing pneumonia or appendicitis or other infections, they can also predispose to the septic shock in such cases. Now, coming to the nomenclature, there is a systemic inflammatory response syndrome, which is characterized by either hyperthermia or hypothermia. Then WBC is more than 12,000 with immature neutrophils, and there must be associated clinical evidence of infection also. But in the shock, septic shock, sepsis with the hypotension, even if adequate fluid resuscitation is there, adequate fluid is there, there will be an evidence of infection. Then when we are going to do the cultures, there will be positive cultures. And it is a refractory hypotension, may not respond to the proper fluid resuscitation. So these patients will require vasopressors or inotropic drugs. This sepsis may be associated along with the hypotension, hypoxia, oliguria, multi-organ failures, metabolic acidosis, thrombocytopenia, sometimes may lead to disseminated intravascular coagulopathy. The symptoms are, everybody knows, in a starting it is fever, later on maybe converting to the hypothermia, then vomiting, diarrhea, abdominal pain, then tachypnea, tachycardia, pallor, later on cold peripheries, peripheral shutdown, systemic inflammation, then organic hypoperfusion causing confusion, altered mental status, oliguria, effects on the kidneys and bleeding diathesis. So what are the investigations to be done? Immediately when the septic shock is diagnosed clinically, the treatment should be started, but other investigation, a simple CBC or complete blood count may work. Abnormal TLC, DLC will be there. Then there will be low platelets, then low fibrinogen, coagulopathy, coagulation profile is abnormal. There will be abnormal liver function test. There will be raised blood urea, serum creatinine. These are the investigations to be done while we are treating for the septic shock. Now coming to the treatment, initial management is ABC, which requires rapid blood volume expansion to correct if there is any hypovolemia. If the source of the sepsis is fetal component, then delivery becomes an essential part of the active management, and improvement in the maternal hemodynamic stability has a direct effect on the fetal viability. So the treatment is immediate transfer to the tertiary care center, direct arterial and central venous monitoring, intravenous broad spectrum antibiotics against gram-negative and positive organisms, then removal of the infective tissues like evacuation of uterus, DNC, if required, colpotomy, laparotomy, if needed, Scissoring Hysterectomy. So goal-related therapy should be given, and one must send the samples for the culture. Blood sample or high vaginal swabs or amniotic fluid samples, if required, if there is any peritonitis, any pus inside the peritoneum or POD, that should be taken and sent for the culture. And when we must take care of modifying the initial treatment to achieve a mean arterial pressure more than 65 millimeter of mercury, urine output, as Dr. Vidya has also told in the hemorrhage. The same lies here, 30 ml per hour, CVP 8 to 12 millimeter of mercury, and normal mixed venous oxygen saturation. Aggressive control of the blood sugar should also be done to improve the outcome in the septic patient. If it is that, then insulin therapy may be helping in that way. Activated protein C administration decreases the mortality and reduces the organ dysfunction. So these are the treatment to be given in the sepsis. Now coming to the corticosteroid therapy. Actually, in unselected septic patient, it may even worsen the outcome because of the secondary infection. Beneficial effect of steroids in obstetrical sepsis is unknown. Now coming to the third one, that is the cardiogenic shock. That is also very important to be taken care if it is present along with the pregnancy. This occurs when the heart cannot pump enough oxygen-rich blood to the brain, kidneys, and other vital organs, leading to a drop in the blood pressure, state of confusion, loss of consciousness, sweaty skin, and rapid breathing. Most common causes is heart attack, and other causes may be cardiomyopathies, myocarditis, blunt trauma to the heart, or pharmacotoxicity. Pre-existing cardiac diseases further increase the risk, and pregnancy puts a progressive strain on the cardiac functions, peak being between 32 to 34 weeks. Cardiac-related deaths are also quite high. They are the second most common causes of the death during the pregnancy. So it should be looked after properly, it should be treated properly, and we should make the early diagnosis of the cardiac lesion. During pregnancy, a simple ECG can be done, and we can diagnose the things. And before planning the pregnancy, if any operable cardiac lesion is there, that should be done, and that should be corrected surgically. If cardiac conditions are not under control, then we can perform MTP at 6 to 8 weeks. Initial management is the same, and then we should take the help of the cardiologist for the further treatment. Now coming to the anaphylactic shock, maybe because of pharmacological agents, insect stings, food, latex may trigger anaphylaxis. Some drug may cause anaphylaxis in such patients if the patient is having pregnancy. So it is a serious allergic reaction that is rapid in onset and may result even to the death. So a prompt treatment and prompt management, prompt diagnosis is very important. Why it occurs? It's an exaggerated immunological response to the antigen to which an individual has been previously sensitized. It's a type 1 hypersensitivity IgE-mediated response causing the breakdown and degradation of the Merck cells and basophil-releasing mediators into the plasma, like histamine, serotonin, bradykinin, thromboxane, etc. These substances can cause increased mucous membrane secretions, increased capillary permeabilities, and leakage, marked vasodilatation, and bronchospasm. So they should be taken care very urgently in that way. Now coming, I will request, please mute other people.
It's muted, ma'am. It's muted, ma'am.
Okay. Then now coming to the anaphylactic shock. Now, coming to the anaphylactic shock, the symptoms of course, everybody knows these are the very normal, starting with the flushing, urticaria, rhinitis, conjunctival erythema, lacrimation. Then later on, going to the throbbing headaches, confusions, altered mental state, hypotension. Further, there may be problem with the respiratory system, airway edema, wheezing, dyspnea, chest, throat tightness, hypoxia, confusion, cardiovascular collapse leading to hypertension, vasodilatation, cold clammy skin, nausea, vomiting, abdominal pain, etc. These are the important signs and symptoms for the anaphylactic shock. And investigations are not very much important. When the patient comes with the anaphylactic shock, immediately it should be treated, and we should refer to immunologist for the investigation. Immediate investigation can be done, that is elevated serum tryptase indicates the mast cell degradation. 3 samples are taken at first, second, and third hour following suspected reaction. And later on, we can identify the causative agent. Again, the shock management is the same as we are already discussing, that is ABC of the shock management. But 1 ml injection of the diluted adrenaline subcutaneously should be given immediately, and early endotracheal intubation should be done because it may be difficult later on because of the airway edema. Supine position with the raised leg increases the venous return and start the vasopressor drugs in such cases and monitor the blood pressure. Rapid infusion with the crystallers for the plasma volume expansion when and where it is required. If there is significant bradycardia, we can start with the atropine. Because of for the bronchospasm, we can give IV aminophylline or darifylline to the patient and nebulization with the beta-2 agonist. Then antihistaminics and corticosteroids, they have an actual role to treat the anaphylactic shock. So they should be given very urgently and properly. Now coming to the most catastrophic complication of pregnancy, that is the amniotic fluid embolism, in which amniotic fluid, fetal cells, hair, or any other debris enters in the maternal pulmonary circulation. It's a nightmare for an obstetrician. I have also come across such 2-3 patients in my obstetrical practice, and it becomes very difficult to treat them. It will cause cardiovascular collapse. Incidence is around 1 in 80,000 people, characterized by abrupt cardiovascular collapse and coagulopathy during labor or in the immediate postpartum period. Exact mechanism is not clear. The process is very similar to anaphylactic shock. Amniotic fluid found in the pulmonary circulation produces intense pulmonary vasospasm and pulmonary hypertension. When ventilation perfusion mismatch occurs, profound hypoxia occurs. Hypoxia may account for 50% of the maternal death in first hour of its onset. Following initial phase, there is a phase of hemodynamic compromise caused by left ventricular failure. Clinical features are again suddenly when the patient is progressing for the labor or after the delivery, she developed sudden acute dyspnea, hypotension, seizures, tachypnea, tachycardia, blood-tinged frothy sputum, and there is a significant circumulnar and peripheral cyanosis present, fetal bradycardia, dark colored blood which does not clot. Patient may go into DIC, uterine atony just after delivery, severe Pph, leading to pulmonary edema and cardiac arrest. So it is very important to treat, very promptly diagnose and treat the amniotic fluid embolism. This is very important. Initial management is the same, that is the patency of the airway, giving proper ventilatory support, and circulation should be maintained. Then we have to give crystalloids or colloids IV transfusions with vasopressors. And in this particular case, we require fresh frozen plasma and cryoprecipitate and platelet transfusion that can only save the patient. And activated recombinant factor 7A is also being used. Plenty of fresh heparinized blood can save the patient. And if required, we can go for the emergency cesarean. So prompt management for the DIC and left heart failure is really required at the time of amniotic fluid embolism to treat the amniotic fluid embolism along with the supportive treatment. Now coming to the distributive shock. It is caused by abnormal distribution of blood in the smallest blood vessels, resulting in inadequate supply of the blood to the body tissues and organs. No loss in the intravascular volume, but primary cause is a massive vasodilatation leading to relative hypovolemia, reduced perfusion pressure. Poor blood supply to the tissue anoxia. Management is again, as we have already discussed, ABC of the initial management. Now coming to a very important type of shock which can occur during the pregnancy, during the delivery, even in the cesarean. That is the neurogenic shock. It is commonly associated with the cervical or high thoracic spinal injury, characterized by hypotension, bradyarrhythmia, temperature dysregulation due to peripheral vasodilatation, occurs due to the sudden loss of the sympathetic tone with unaffected parasympathetic function leading to autonomic instability. Loss of sympathetic tone causes widespread vasodilatation. Management is again fluid resuscitation, vasopressor drugs, and initial management of the ABC. Atropine is required as bradycardia may happen due to unopposed vagal activity. Now coming to the another type of neurogenic shock that may also occur. It may be due to the any type of anesthesia or analgesia used for the labor. Shock is caused by general anesthesia, maybe due to the adverse drug reaction, and sometimes because of the overdose, because drug dose is reduced in the pregnancy, and sometimes there may be high spinal block by the anesthetist due to overdose of the local anesthetic drug, which is being administered into the epidural and subarachnoid space. Accidental intrathecal injection of local anesthetic agent in the epidural space. Hypotension may be aggravated by the incorrect positioning also. Absence of the lateral tilt cause aortocaval compression. So that may be reason for the neurogenic shock. There will be hypotension, bradycardia, unopposed vagal tone due to the blockage of cardioaccelerative fibers, then difficulty in breathing due to the paralysis of intercostal muscles and diaphragm. Then upper limb neurological signs will also be there, and patient may develop hypotension. Immediate treatment should be given in the form of ABC, as we have already discussed, along with the proper intravenous fluid resuscitation. Then second line treatment is the vasopressors and inotropes. If there is bradycardia, atropine and glycopyrrolate should be administered to oppose the vagal tone before suctioning. Then endotracheal intubation and ventilatory support is very much required in such cases. After the initial resuscitation is achieved, we can use some amount of the sedatives to reduce the awareness. Now coming to the another neurogenic shock. That is again because of the intravenous injection of the local anesthetic agent while we are giving regional blocks, pudendal blocks, paracervical, episiotomy or caudal blocks. This again occurs during the subcutaneous infiltration of the epidural top-up. Causes increase in pregnancy, there is an increased blood supply, so it aids to the rapid absorption of the local anesthetic. Clinical features are again confusion, lightheadedness, loss of consciousness sometimes, causing generalized tonic-clonic seizures, tinnitus, dizziness, circumaural numbness, metallic taste, anxiety, respiratory depression. There may be dysarrhythmia, tachycardia, tachypnea, hypotension, and refractory cardiorespiratory arrest. It should be treated in a proper way. Life support may be required with the external cardiac massage sometimes and defibrillation. It may be resistant to conventional therapy. So basic shock management should be associated along with these things: vasopressors, inotropic drugs, and the proper treatment. Endotracheal intubation, ventilatory support may be needed in such management of the neurogenic shock. We may need to do LSCS to salvage the baby, and lipid rescue therapy can be given. To conclude, shock results from acute generalized inadequate perfusion of the tissues. Substandard care in the shock leads to increased mortality rate. Sepsis or hemorrhage are the common in obstetrics. Sign of hypovolemia develops very late because of the physiological changes in the pregnancy. Teamwork is required for the successful treatment. Free drills and regular training to the staff is required to treat whatever obstetric emergency comes in, maybe Pph, maybe hypovolemic shock, maybe any other type of shock. Resuscitation to maintain the tissue perfusion by ABC of the treatment should be initiated as soon as the shock is diagnosed, and it is made clinically mostly. Management of the underlying cause is a secondary task. First, we have to revive the patient, we have to resuscitate the patient, and when condition becomes slightly better, then we can think about the management of the underlying cause. And therapy is directed to optimize maternal condition and fetal well-being. Thank you very much.
Thank you, Dr. Archana, for your crisp and detailed deliberation. One thing I want to highlight is these are the cases where one must remain prepared to be sued. And once again, I will emphasize proper documentation. Everything what you have done and proper explanation of the patient's condition to relatives and prognosis also is must. And rest all Dr. Archana has told. Thank you.
About the documentation, actually, Dr. Ajay has elaborated so nicely.
Yes, ma'am, but
in a wonderful way. So that's why I have not discussed even the Pph and hypovolemic shock very much, because Dr. Vidya Thobi has given such a wonderful presentation. I need not to tell about that.
I myself have gone through such a case, so I want to emphasize
I also
experience.
My experience of one of the amniotic fluid embolism.
Yes, ma'am. It is a complete nightmare, ma'am.
Complete nightmare. I just cannot forget in my life 2 or 3 patients.
Yes,
2 I could refer in time to the AIMS or somewhere in GTB, and one of the patient died in my hospital. And after that, so much things to.
मैम अभी सोच के goosebumps आ जाते हैं.
हाँ, सोच के घबराहट हो जाती है. You are very right. But amniotic fluid embolism का incidence अच्छा खासा है. मतलब it's not.
Yes, ma'am. It is underreported. Incidence अच्छा
It is underreported. Incidence अच्छा खासा है.
Thank you.
Thank you very much. Thank you very much, Dr. Reenu, Dr. Seema, dear Kanchan.
Thank you so much, ma'am, for this giving the overview of all kind of shock, because we as an obstetrician, we need to know how to manage not only the control bleeding, we have to know how to manage the shock also, because many a times bleeding stops, but patient land into irreversible shock, which we cannot able to now save after that. So management of shock is as important as controlling the bleeding in PPH. And ma'am so nicely covered each and every aspect of shock. Thank you so much, ma'am.
I try to tell about whatever all the shocks, because treatment since evening we are listening to so many teachers, so many good speakers to elaborate all the things and to tell what should be done, what not should be done, the practical aspects, in the medical legal aspects. So it was actually that way only.
Yes, ma'am. Thank you. Brilliant talk, ma'am. Thank you so much.
Thank you, Dr. Archana Sharma, ma'am, Dr. Kanchan, and Dr. Manisha. Now, moving ahead, the next topic is blood transfusion protocol. Chairpersons are Dr. Shishmita and Dr. Samta Gupta. Inviting Dr. Shishmita. CV, please. Dr. Shishmita is Professor and Unit Head, Department of Obs and Gynae, SCV Medical College, Cuttack. She is National Medical Council, Scissoring. Welcome, ma'am. Dr. Samta Gupta, Senior Consultant, Professor, Obs and Gynae, School of Medical Science and Research, Sharda Hospital, Greater Noida. She is Treasurer, Greater Noida Obs and Gynae Society. Welcome, Dr. Samta. Now I invite Dr. Shishmita to introduce our charming, ever-smiling, polite Dr. Vinita Mittal. Dr. Shishmita?
Yes, I'm there. So good evening, everybody. So first of all, I must thank the organizers and especially Archana Madam for giving me the opportunity to be a part of this very well-planned, very well-organized webinar of West UP ISOPAV. I must also congratulate young achievers, Dr. Niharika and Dr. Neha. And now coming to Dr. Vinita Mittal. She is a very senior practitioner of Ghaziabad. She is a very active member of Ghaziabad Obstetric Society. She was the president, vice president, secretary, all posts she has achieved of Ghaziabad Society. And she is also an active member of IMA. She has been awarded many prestigious prizes, and she has done also many community work, many public awareness programs like on cancer cervix, adolescent health, hemoglobin, polio drops, cervical cancer detection. She has done many public awareness programs, and very important, very beautiful, she is doing mother-daughter program in schools. That is also a very unique program I found. So welcome Dr. Vinita Mittal. Today she is going to speak on massive transfusion protocol. This is very important to know, as since evening we're discussing all the causes of bleeding in obstetrics, and when we're going to give massive blood transfusion, that is more than 10 units in 24 hours or more than 5 units of blood in less than 4 hours, that is called massive transfusion. But if you give massive transfusion, what is the problem? Because it causes dilutional coagulopathy, and which may result in refractory hemorrhage because of hemodilution, because of deficient calcium, because of sometimes we may give cold blood and acidosis. All these things again will lead to refractory hemorrhage. So to counteract that, we have to know the protocol of massive blood transfusion. Some ratio has to be maintained, that we all must know. So today now, Dr. Vinita will be going to elaborate on this subject and make awareness to all about this program. Welcome, Dr. Vinita. Please.
Thank you, Dr. Sanita, for such wonderful and kind words for me. You've been very, you made me so humble to introduce me like and you liked my mother-daughter program.
Yeah, what is that program? I just want to know a little bit about.
Actually, it's about like say no to all the touches and be open to your mother.
Okay.
And because it's in a co-ed schools and all, co-ed schools, so the children should be very much aware of what hygiene of menstrual hygiene and or like what they should be doing with the boys and girls, and what should they be and what consequences and all.
Okay.
Thank you so much. And I'm grateful to our dynamic president, Buddy Archana, my charming, ever-smiling, energetic secretary, Dr. Seema Vashne, and the diligent and humble Renu for making me part of this wonderful and important webinar. My regards to Dr. Kriplani, Dr. Usha Sharma, and Dr. Krishna Kumari, and all the stalwarts who have been the topics today, and I'm honored to be talking amongst them. Thank you so much. And my topic, I'll be sharing my screen. Is it okay?
Yes. Yes.
So it's massive. I hope I do justice to this topic. Massive blood transfusion protocol. This is the topic. Actually, we have to know what is transfusion before we go for the protocol. So the massive transfusion is when the patient, we are giving 10 units of RBC in 24 hours, or total blood volume is replaced within 24 hours, or 4 units within 1 hour, or 50% of total volume is replaced within 3 hours. In pediatric patient, it is transfusion of more than 100% of total blood volume within 24 hours. Support to replace ongoing hemorrhage of more than 10% total blood volume per minute, or replacement of 100% of total blood volume by blood products within 3 hours. When? Yes, that is when bleeding excessively. Either it is because of trauma or surgery of liver or cardiovascular, less frequently abdominal aneurysm, aortic aneurysm, liver transplant, or GI bleeding. And in our case, it is PPH. Beautifully and wonderfully, Archana Sharma has explained us about the shock, and my transfusion goes for hypovolemic hemorrhage. Massive blood transfusion established to provide rapid blood replacement in a setting of severe hemorrhage. Early optimal blood transfusion is essential to sustain organ perfusion and oxygenation. Type of components, what is the challenges? What type of components to be administered? Selection of the appropriate amount. And the most important is time. How? Now comes what is medical transfusion protocol. Medical transfusion protocol in a way to coordinate the care of patient requiring massive transfusion, to facilitate communication different services, trauma, nursing, transfusion medicine, and other laboratories, avoiding delay in clinical care, laboratory testing, and blood product transfusion and nursing care. MTP is a way to assure good patient care by making standard protocol on specific actions to take for each service involved. Medical protocols have demonstrated, transfusion protocols have demonstrated improved patient survival and reduced rates of organ failure and post-trauma complications. The steps which are involved are, we have to first of all identify which one needs a massive transfusion. Then we need to inform the institute which are having MTP protocols. We have to inform the blood bank, the laboratories, and the hospitals, tertiary care. Optimize intrinsic coagulation, that is, avoid hypothermia, put a quick IV line, and blood products. We can administer transaminic acid IV over 1 gram, and within like 1 gram in 8 hours. Then we have to arrange for arrival of cross-match blood, FFP, plasma, and PRBCs. Sorry. We have to recheck the CBC, INR, PTT, fibrogen, ABG, creatinine, magnesium, calcium for monitoring hypokalemia, hypocalcemia, hypomagnesemia, replace calcium and magnesium parenterally to avoid cardiac arrhythmias. We have to wait arrival of additional blood products like fibrogen, cryoprecipitate, platelets, and maintain the INR. And in the end, we have to see when to stop MTP, and we have to inform the blood banks for that. There are packages of, in the hospitals, packages of MTP, the first box containing 2 whole blood or 2 whole blood with 2 FFP. The second one, after 35 minutes, MTP box 2 with 4 RBCs with 4 FFP, 3 cryoprecipitate. The third box containing 4 RBC, 4 FFP, 1 platelets. The fourth box containing 4 RBC, 4 FFP, and 3 cryoprecipitate, and alternate 3 and 4. As the patient condition is improving, we have to keep, or deteriorating, we have to keep managing that. There has to be a team of leader who has to be responsible for this. He has to inform, he has to be registered, so that he can tell the blood bank that he can have blood if it is very urgent, even before cross-matching. They have to notify the coagulation lab and send coagulation request forms. Activate protocol by ringing blood that I am activating the massive transfusion protocol. Make decision to cease massive blood transfusion protocol and contact blood bank. Now, blood bank responsibility to ensure they can release O negative blood, notify the when the fourth box is going. They have to wait for the thawing the. Is my net all right? Because here I'm having some problem.
Yes, it is all right.
Then the blood bank has to prepare for thawing for as the people are fourth box, and the platelets too. Now, classification of hemorrhage. I come in the 4th category. The first category we need to observe if it is 750 ml, no major changes in healthy person. 750 to 1500, there will be tachycardia, narrow pulse pressure, mild or moderate hypotension, compensatory peripheral, vasoconstriction, mild medical confusion. We have to give fluid therapy. If the bleeding is from 15 to 2000 ml, hypotension, peripheral hypoperfusion, mental confusion. We need to give fluids, blood if hemoglobin is less than 7 grams, and shock. Yes, Hypovolemic shock, we need to have blood transfusion. Now, principles of management of massive blood transfusion is, it is vital component as we have to give blood because it is a vital blood loss management. Physiologically or hemodynamically compensatory mechanisms maintain vital organ perfusion till about 30% of total blood loss. Beyond that, there is a risk of critical hypoperfusion. Inadequate resuscitation at this will lead to shock. It is important to remember that overzealous resuscitation leading to high arterial and venous pressure may be disastrous as it may dislodge hemostatic clots and cause more bleeding. Now, along with just as the existing, we have to start with an IV crystalloids 20 to 30 ml kg per bolus. Then we have to get blood products 1:1:1. This is the protocol that we give PRBC, 1 fresh plasma, and then platelets should be given. A mean arterial pressure should remain 65 mm, that is systolic blood pressure 90. Typed uncrossed PRBC are best, but it is not available, then we can immediately give RH negative for blood for the transfusion. And hypothermia has to be controlled. Immediately we are giving negative. If there are minutes, we can give a quick blood cross match, and if we have hours, we can have a complete cross match. If the units are issued without X match, written consent of the patient, of the person who is in charge should be there. And later on, the cross matching should be done. Additional treatment threshold, if PNR is more than 1.5, 4 units of gram per liter. At platelets, if ionized calcium is less than 1 millimoles, give 10 ml of calcium. Early management of circulation, we have to put 2 IV lines in the patient. One, give bolus normal saline in 10 to 15 minutes. Blood or blood substitutes have to be given 40 to 60 ml per kg in shock who are not responding to crystalloid infusion. A transfusion ml per kg of packed red blood cells should be considered if there is an inadequate in clinical improvement even after 40 to 60 ml of normal saline. The blood products we are using are packed cell volume, plasma, platelets, and cryoprecipitate. Patients who have sustained traumatic or who need massive transfusion should be receiving 1:1 ratio of FFP to platelets to RBCs and the outset, their resuscitation and transfusion therapy. We have talked about that O negative blood in 5 minutes can be given. AB platelets of AB or B plasma can be introduced. So uncrossed matched blood, O negative can be given as whole blood. Residual plasma with both antibodies, anti-A and B, can be accumulated when large transfusion are transformed. Repeat blood group and do antibody titers before resuming transfusion of RBC. Important is at the outset, aggressive fluid replacement and bleeding control can be reduce the tissue injury, inflammation, and hypotension. Ultimately, untimely or incomplete control of massive bleeding systemic consumption coagulopathy with hemodilution and endothelial damage. If uncorrected, concurrent hypothermia and acidosis can occur, they can lead to coagulopathy and further lead to multi-organ failures. IV tranexamic acid can be given at a dose of 1 gram in 10 minutes and followed by infusion of 1 gram in 8 hours. This inhibits fibrolysis. In Crash 2 trial, it was seen that tranexamic acid given within 3 hours of injury would reduce all causes of mortality and morbidity from bleeding. without increasing the rate of vascular occlusion events. Platelet transfusion, it becomes necessary after 2 volumes of blood loss, 10 to 12 units of transfused RBC, 50% fall of platelet is there. So platelet concentrate should be transfused as 1 pack, 100 kg body weight. Fibrogen concentrate is there, but it is very costly, and now and its availability is also a point. So we are trying precipitate nowadays, which is made by controlled thawing of plasma, frozen plasma at 1 to 6 degrees Fahrenheit. Most product used to replace fibrogen, containing approximately 200 to 250 milligram of fibrogen per unit. Standard dose of 5 units should be given in management of obstetric hemorrhage. Subsequent cryoprecipitate transfusion should be guided by fibrogen timing, and this level, if their level are above 1.5. So the targets, how to go along with massive transfusion, the blood pressure, we have optimize oxygenation, cardiac output, tissue perfusion, and metabolic state. We have to monitor every 30 to 60 minutes the full body blood count, coagulation screening, ionized calcium, atrial blood gases. Aim for temperature. The temperature, which should be more than 35 degrees centigrade, pH 7.2, basic excess less than 0.6, lactate less than 0.4 millimoles, calcium more than 1.1, platelets more than 30, PT, APTT less than 1.5. Now, prevention of hypothermia is cover the patient, and the blood we are giving should be, the commercial blood warmers should be used. We have to control hypotension, which so that the mean arterial pressure remains 50 to 80 ml in patients without brain injury. Hypokalemia, citrate binds calcium, results in small pulse pressure, flat ST segments, and prolonged QT intervals for ECG. If it is there, then ionized hypocalcemia develops, then of calcium gluconate, 10 to 20 ml should be given intravenously, other vein, for each 500 ml of blood transfused. What are the complications which can occur because of blood transfusion? Volume, overtransfusion, hypothermia, coagulopathy, acute lung injuries, hypokalemia, hypocalcemia, and disease transfusion. So they are related to each other. Once we have severe trauma, there will be bleeding. The bleeding will lead to tissue hypoxia, which will further lead to acidosis and coagulopathy, dilution coagulopathy. Now we are giving a lot of crystalloids, massive transfusion, which will again lead to, sorry, I think my sharing is stopped.
Yes.
Fine. Tissue hypoxia, hypothermia, dilution, again, it will lead to coagulopathy, dilution coagulation factors, because once we are giving a lot of blood, there will be dilution of coagulation factors and platelets, which will again lead to coagulopathy. And so they may be, it may lead to, sorry, acidosis and hypothermia. It interferes with formation of coagulation factor complexes. Hypothermia further reduces enzymatic activity of coagulation factors. It prevents activation of platelets. Coagulopathy can be dilutional coagulopathy, disseminated intravascular coagulopathy, or consumption of coagulation factors. 500 ml of blood loss replaced drops the activity of coagulation by 10%. 8 to 10 units of PRBC, coagulation activity drops by 25%. Dilution coagulopathy followed by massive transfusion is a consequence of post-traumatic and post-surgical hemorrhage. Bleeding followed following massive transfusion can occur due to hypothermia, dilution coagulopathy, platelet dysfunction, fibrolysis, or hypofibrinogenemia. Transfusion of 15 to 20 units of blood products causes dilution, thrombocytopenia. Large volumes of crystalloid fluid used for these cases can contribute to dilution coagulopathy. So clinically said that 1:1:1 is the ratio which when followed reduces in massively injured and rapidly patients should be followed to reduce dilution coagulopathy. The first peak of death may occur in seconds to minutes immediately after injury, and only prevention can be the mortality. But we come second and the third. Second peak occurs minute to hours after injury, where we have to give massive blood transfusion if she's bleeding. During this period, these are referred as golden hours. Rapid assessment and decreases fatalities and improves outcomes. Third peak of death is due to infection after days to week. Now, the summary why the protocol is important: need to define protocol triggers and algorithm for preparation and delivery of blood products include continuous. The protocol should be updated annually and practiced in skill drills to inform the trained personnel. And we have to be, during this period, we have to keep calm and composed. This is the chart which this is a chart for massive transfusion protocol, which should be there for institute where this procedure can be followed, so that we have to go. This goes on. And thank you for patient listening. Thank you, Dr. Samita and Dr. Samta.
Thanks, Dr. Vinita ma'am, for such an informative talk on massive blood transfusion protocols.
I hope I did a little bit of justice in this.
Yeah, sure, ma'am.
Excellent.
Blood transfusion is our safety resort in the obstetric emergencies, and we all face with such kind of emergencies where we require massive blood transfusion protocols. So ma'am has rightly said that the massive transfusion protocol is 10 units in 24 hours or 4 units within 1 hour. But we all should be aware of the complications, that is dilutional coagulopathy, with the massive blood transfusion protocol. Ma'am has very nicely told about the MTP box, what all is contained in the MTP box regarding blood, FFP and plasma. And we all know in the massive blood transfusion protocol, that is PRBCs, fresh frozen plasma, and the FFPs are in the 1:1:1 ratio, and we should maintain the mean arterial pressure to 65 millimeter of mercury. And one of the important things, we should always have all the consents for blood transfusion, and our intensivists should be there so that we are able to tackle the complications of massive blood transfusion, like TRALI, that is transfusion related lung injury, which is quite common with the massive blood transfusion protocols. At the end, I would
thank you, Dr. Samita, for highlighting that. Dr. Ajay, I was thinking of saying that, but I just missed it.
Thanks, Renu ma'am, Dr. Archana ma'am, and Dr. Seema ma'am for giving me this opportunity to be a part of this informative webinar. Thank you so much, ma'am.
It was an excellent talk. Actually, I also like the slide for the bloods are dropping down. Unique slide that you have made.
Thank you.
Very cute. Okay, very excellent talk. Actually, if you don't know the protocol, we will again land with refractory hemorrhage. It will be a vicious cycle. So all of us has to know the protocol and must follow it. Thank you.
Thank you.
To Dr. Vinita Buttal, Dr. Sashmita, Dr. Samta, thank you for all.
With organizers' permission, I may be allowed to appeal to vote for me. I am contesting for chairman.
Sure, very sure.
Yes.
Yeah, ma'am, I just received your phone also.
Okay, ma'am.
We are very much there and we are going to surely vote for you.
Okay, thank you so much.
We are with you, madam. We are with you.
Okay, very nice webinar.
Thank you for coming, and
Dr. Vinita has done justice with the topic, and she has explained very nicely. And
Thank you,
Dr.
Seema.
Archana Sharma, all the speakers were very.
Thank you for the motivating words.
it was nice and very informative, very elaborated.
Very elaborate.
Thank you so much.
Thank you. So, Dr. Renu, will you be giving official thanks?
Yes, आप ही दे दीजिए. Official.
You give.
5 times thank you is done. 5 topics.
Thank you is really done.
Official thanks.
Dr. Archana Sharma and Dr. Mane sir or Dr. Vidya Thobi, all were very excellent. Dr. Poonam, very informative talks. All talks were very useful in our day-to-day practice, and we can we gained a lot today, and it is a very important topic. And Dr. Archana Verma choose every time very difficult and untouchable topic. So thank you, Dr. Archana Verma, and I am grateful to our chief guest, Dr. Alka Kriplani, Dr. Usha Sharma, and special guest, Dr. Krishna Kumari, and all the eminent speakers and all the chairpersons who have given their valuable inputs. So, and last but not the least, IT people for giving very smooth platform. So, thank you everyone. Dr. Vinita, आप कुछ कह सकती हैं?
क्या कहूँ? I'm amazed. People were so good in talking. It was so good. And Dr. Samita ने तो पहले भी बता दिया कि क्या करना. But I was little, मेरे को डर लग रहा था थोड़ा सा क्योंकि ये first time आया था और बहुत ज़्यादा difficult था. I didn't know. And कल मैं भारतपुर से लौटी हूँ and I made it. But I don't know. If there was any flaw, I would ask Professor Samita to just highlight that.
अब हम क्या करें? सारे तो 3 लोग पहले सब कुछ तो पढ़ा के चले गए. डॉक्टर विद्या थोबी ने इतना डिटेल में पढ़ा दिया कि हमारे लिए कुछ बचा ही नहीं बोलने को.
नहीं मैडम, आपने बहुत अच्छा पढ़ाया ऑब्स्टेट्रिक शॉक.
और ऊपर से डॉक्टर अर्चना वर्मा ने स्टार्टिंग में डांट.
You are always speaking very good. You are a great speaker. And I was speaking for the first time.
नहीं ऐसा कुछ भी नहीं है. ऐसा कुछ भी नहीं है. अब मैं
You are speaking for the first time. It was more than excellent. It was more than excellent. You have touched every aspect. You have touched every aspect. It is very
विनीता जी, लेकिन आपने ट्रांसफ्यूजन बहुत अच्छा पढ़ाया. Thank you very much.
Okay.
Thank you so much. Actually, when you're not doing anything, you're not practicing anything, then you need to, if you speak about it, you actually are not very practicing. Once you are practicing something and you have to speak about it, it becomes easier. But once you're not practicing anything and you speak about it, you just keep saying kuch galti na ho jaye.
Right.
Ma'am, the best thing is that whenever you prepare these talks, you learn so much.
Yes, that is the most important.
I totally agree to you, ma'am. I totally agree.
Because it makes you learn so much, so every webinar is a lot of learning, one should never think that.
I agree to you, Dr. Preeti. I really agree to you. Thank you.
Dr. Samta, you want to say something? Dr. Samta? Samta, are you there? Has she left?
There. Thank you, Seema ji.
Thank you,
Seema ma'am. Everybody, and Kanchan, thank you.
Thank you, Archana ma'am. Thank you, Renu ma'am. And thank you, Vinita ma'am. And thank you,
Madam Kanchan, Dr.
Thank you, Dr. Kanchan.
Bye-bye.
Bye-bye. Good night.
Good night.
Have a relaxed night today. Be relaxed and be happy as there's no webinar tomorrow.
You too. You sleep quietly today.
Yeah, I will sleep soundly. I'll sleep. Have a good sleep today.
Good dreams.
हाँ सीमा, अब बताओ ठीक था? अब तो सब चले गए.
अच्छा, बहुत अच्छा था मैडम.
ऐसा है ना, सीमा तो हमेशा अच्छा ही बताएगी, चाहे हम कुछ भी बोल रहे हो.
नहीं, ये गलत है. मैं सीमा से कह रही थी, सीमा ने कहा था मुझे सुना देना.
नहीं, डॉक्टर विनीता,